Today is our bi-monthly health district meeting. Today is Monday or Friday, March 22nd. This time I will call the meeting to order and have roll call. Excuse me. From Ada County, Dr. Ryan Cole. Dr. Cole, are you on? Don't see him. Dr. Furch.
Here.
Dr. Young.
Here.
From Boise County, Commissioner Clay Tucker.
Here.
Trustee from Elmore County, Betty Nettleton.
Present.
And we just got notice that Crystal is on her way, but late. So that being enough numbers, we do have a quorum. So we will continue on down with your agenda. This is an action item. Is there any additions or changes to the agenda? Oh, good. Good to see you.
Good morning.
Please note that Dr. Cole is here. We're at the second agenda item, Dr. Cole. This is an action item. If there's any changes to the agenda, if not, I need a motion to approve as presented. Okay, do we have a second?
I'll second.
Got a motion and a second to approve the agenda. All in favor, please say aye.
Aye.
Any opposed?
What?
Motion passes.
I turned it off.
Okay, the next agenda item is also an action item. This is
Should be
discuss and
off
vote on the
notification.
February 16th Board of Health meeting minutes. Oh, really? Everyone is good with those. I'd entertain a motion to approve those. Another second.
I will second.
We got a motion and a second to approve the February 16th health minutes. All in favor, please say aye.
Aye.
Any opposed? Motion carries. Kind of moving ahead of schedule is Jack here. Oh, you're okay? I didn't get your news, that's why. So at this time, we're gonna move on down. This is not an action item, it's a review and discuss section 218 of the Social Security Act. So Jackie, I'll turn it over to you.
Thank you so much for allowing me to attend today. As mentioned, my name is Jackie Lee. I work for the State Controller's Office. I am the State Social Security Manager. So you may or may not be aware, but the health districts will all be partaking in holding a vote on Social Security and whether your employees are going to participate in paying Social Security or not. So we'll be going through the vote process for the next few months, and we're working out an exact timeline. But what I would like to do today is to explain to you what is happening, how kind of we got here, and then hopefully answer any questions that you might have, and so you understand as a board what decisions you may or may not want to do. So with that, I always like to start with a little bit of a pre-record, and I apologize for those of you that have heard this before. But sometimes that's the easiest way to explain why we're here and what is happening right now. So when Social Security was created back in the 30s, it actually excluded government employees. And they added, back in 1951, Section 218 of the Social Security Act, which allowed government employees to participate in Social Security. But at that time, when it was created, the only way that a government employee could participate in Social Security is if they were not already part of a retirement system. So essentially, you could have Social Security or you could have a retirement system, and those were your two options. It wasn't until 1954 that they amended Section 218 of the Social Security Act, and they said, all right, we'll allow for government employees to participate in Social Security, but the only way that they can participate is they have to have, or the only way they can participate in Social Security and have a retirement system is if they hold a vote, which that portion of the law has really not changed since that time. So as health districts, you are a member of PERSI, so that is the retirement system. And so if you'd like to participate in Social Security, a vote needs to be held. There was previous understanding that the health districts were part of the larger state agreement. So like what health and welfare or transportation or labor is under. But through review and further discussions, health districts really are their own entities. And that was made especially clear when you guys got your own EIN numbers, right? So now this is kind of giving us that mechanism to be able to hold a vote where we can actually let each health district decide whether they want to participate in Social Security or not. So How this will work is we will determine who the eligible employees are. To be an eligible employee, you have to be a contributing member of Percy. And then also, you have to be in an employment relationship for the entirety of the vote process. So normally, the voting process is about 90 days. If we have anyone on military deployment, which we will have for you guys, it adds an additional 60 days so we can make sure that they get their ballots for wherever they may be while they're out deployed. So where it is eligible employees are people who are contributing to Percy, that also would include the board members. So you guys will be partaking in the vote as well. So it's not just regular staff, but also you. So keep that in mind as we go through the process. I'm going through my notes. I promise I'm not just checking my phone here. So as we go through the vote, as I mentioned, your employees will be able to determine whether they want to participate in Social Security or not. The question that normally we like boards to think about before a vote takes place is if your employees were to vote no, that they do not want to participate in Social Security anymore. Normally boards have already set their budgets of X amount for personnel goes towards the Social Security tax. So then what happens to those funds if they decide they don't want to participate anymore? And as far as the federal government is concerned, we have no jurisdiction on what happens to those funds. And it really is up to the boards to make a decision, if they so choose, on what they'd like to do with those funds. Just as information, I'm not suggesting anything. I always like to give my little disclaimer here. The state controller does not vote for or against in any of this. We really just want to provide information. So when I give suggestions, it's just helping you be informed, not trying to sway one way or the other. What we have seen done in the past for entities that have voted no, the board or appointing authority has essentially created 401k accounts for those employees and put those monies that would have gone towards Social Security into a 401k. So that way the employee is still receiving those funds. That's not something, again, that has to be done. That's just something that we've seen in the past for a no vote. Other things is you have it completely within your jurisdiction that if you wanted to put it into like operating or something like that, you're not required to give it back to the employee. It really is up to the appointing authority to decide how you want to handle those funds. One thing that I would maybe suggest is the decision of what happens to those funds. I can tell you that the employees are normally very interested to know what you would like to do with those funds, and that sometimes can help sway for or against what the employee is going to vote on, knowing what's going to happen to those votes if there was a no vote. And so that can really help when they're marking that ballot to know if I vote no, what is going to be the outcome? Is that, am I getting extra money in a 401k? Is it going to go somewhere else? And so that just helps them be better informed and make a decision. So normally that's why we like to come out here, talk to the board, so that way you guys understand what's happening with the vote. And then hopefully I can answer any questions. So that was a very high level description of what's going on. I'm happy to answer any questions regarding the voting process if you want to get into that detail, or any other questions you might have regarding Social Security.
Well, Jackie, I appreciate that. I think that makes it a little more understandable for me. Laurel, how are we doing? We don't do Social Security, do we? No, right?
Yeah, we contribute.
Oh,
now.
we do?
Really do. Yeah, we have been operating under the previous state agreement. And as Jackie said, we now have the mechanism with our own EIN. And now that LUMA's rolled out, one of the benefits of LUMA is that we can now opt in or out because there's a separate programming in LUMA that would account for that for us.
So we do have existing Social Security funds.
Yes.
So I guess maybe I'm not who to ask here, but if we do a vote, I'm assuming that each employee would be allowed to vote on that. Is that how you guys are going to tackle this?
I'm happy to answer that question if you'd like.
Okay.
So all employees who are a contributing member of Percy will have a ballot mailed out to them. So we do all mail-in ballots.
Oh, okay.
And so every employee that they have to be a contributing member of Percy, that really is the trigger item. There's another set of laws that if you're not part of that retirement system, there's mandatory Social Security coverage. So that retirement system really is our trigger point, but anyone who is contributing, including board members, will receive a ballot and will be making that decision. One of the things that maybe might be a good time to bring up is for it to for the vote to pass, it is a majority, half plus one of eligible voters. So that is slightly different than what we deal with in like a regular election. So normally for a voting, it's whoever shows up to the ballot and you count those ballots that are shown up. How the vote works for Social Security is we determine the number of eligible voters prior to sending out the ballots. And that total number is what is going to determine what that majority is. And so if someone decides to not send a ballot back, we consider that a no vote, that they do not want to participate in Social Security. So we really want to make sure that every employee really is making a decision. Or I should say every eligible employee is making a decision on whether they want to participate in Social Security or not.
So that helps a lot, because that was my next question is, do we have to pay for that election or that
We
vote? So the controller's office is doing all that. When is that gonna happen, you know?
So we're still finalizing the timeline. Definitely, our goal is to have it in 2024, but I don't know if you guys want to add any.
Well, I guess my message will be before budget time.
The vote will not be complete by budget time. Our plan is to kick off April 1st, which would have completed it just after the start of the next fiscal year. But as Jackie said, with having a staff member on military deployment, it will extend it that extra 60 days. So we will be into the start of FY25 before the ballots are complete and counted.
Mr. Chair,
Yeah.
besides you all having the opportunity to vote yourselves as eligible employees, a decision point will be what we would do with the Social Security money that the employer contributes. And as Laurel and I talked about this, we'll budget as though that money would be needed as far as the employer's share. And if we get to the point where it's a no vote, and what needs to be determined really by the board, Jackie explained that, is what do you do with that money? So that's probably the key decision point that needs to be made, not at this meeting, but probably the next meeting after you guys have time to think about it. Jackie and Rachel are available to answer more questions. We could work together to talk about how that might be structured so that employees are crystal clear by the time they vote whether or not the share that the employer has been contributing would somehow be put into like a 401k as, I don't know if we call it match contributions or how that might be structured. So that makes sense. So the decision point is what to do with the Social Security money that we're already contributing. Budgetarily, I don't think it's going to make a difference. I mean, we'll budget for it anyway.
Laurel, do you have any idea how much money we're talking about as far as the employer match?
Ask that question to Conan.
Um,
Where we're at currently.
I haven't looked at the numbers yet, but I could have that number to you later.
Well, I think, I guess what I'm kind of wrestling in my mind is the employees knowing, okay, that if I don't vote for Social Security, what's going to happen to my money? They need to know that before they vote. Does that make sense? So we should probably think about putting this on as an action item next meeting to decide how we're going to approach that. To me, if that's the employees' money, it should go where they want to go if they don't want to stay in Social Security. However, guys like me, that's only months away from collecting, that really appreciate your deposit. I'm not far.
I have a couple of questions.
Sure.
Retirement wise, can they have Percy and a 401k?
Yes, they can have Percy. So one's a defined benefit plan, and then the 401k is not a defined benefit plan. So you can have both of those. We've seen them. There's other districts. I'll throw one out. So like Nampa Fire District, that's something that they chose to do. So they ended up voting no. Their firefighters do not pay into Social Security. And so they have their regular Percy contribution. And then those monies that would have normally gone to Social Security are actually going. And I might be wrong that it's a 401k specific because they worked out that portion with Percy at the time, but it is something very similar to a 401k, if not one. I just can't remember the exact mechanism that they used.
Mr. Chair, Jackie, will those
specifics be spelled out on the ballot?
So for the ballot, the only portion that the ballot determines is whether they're paying into Social Security or not. Anything outside of that question really resides within the board and you communicating with employees on what those decisions are, but we try and quote unquote stay in our lane when it comes to that.
So it's up to us to make that clear. Or as a board, I'm remembering something from the past. We don't make enough to make this choice, or do we? I mean, I remember not being able to participate in retirement because of the little amount that we made. Yeah.
I'm not sure I understand what you mean. Are you saying as a board member to
Yeah.
participate? So really those eligibilities is a contributing member of Percy. So if any part of your paycheck or funds that you receive from the board have a Percy contribution, then you become an eligible employee. And it's my understanding that is true for.
Regardless of what is our thing, we can.
You have to contribute to Percy.
Right.
Like each of you do, your $75 per meeting, whatever. Yeah.
Okay, thank you.
Dr. Fritz, go ahead.
Mr. Chair, I maybe should know this, but is the state matching Percy or is that just singularly an employee contribution?
So there is an employer share and an employee share.
So they're
Percy.
both. So if they elect to be in both, then so the district is currently budgeting both the way it is right now. Okay, so then the determinant for whether or not to vote would almost solely be what happens to the employer match.
It could be.
So what other scenarios or what other reason would someone not vote no on staying in Social Security?
So this one's kind of a hard one to answer because everyone has their own personal story and their own view and political beliefs maybe about what Social Security is and what it will provide in the future. So there are some folks, as I've gone through educational meetings, that they don't believe Social Security will be around by the time they retire. So they would rather kind of have control over those funds. And so that's their own opinion on it. Again, I'm not saying any of these are right opinions or wrong opinions.
Sure.
But that might be a reason that someone does not want to participate in Social Security anymore. I have not come across a time in my career yet that a board has not given those funds back to the employee. So for them, it has always been, I will still receive those funds in some form or fashion. And so really for them voting no, sometimes we see it with our emergency service group. So firefighters, police officers, that they are often our ones that vote no because their careers are so much shorter. And so during their shorter parts of their career where they're doing the emergency services, they essentially are getting a bump in pay or putting more in that investment. And then they'll still have a career after where they were getting their credits for Social Security. So in their mind, right or wrong, they believe like, hey, I'll fill up that investment portfolio and then get my credits on the end or something like that.
Mr. Chair, so just to be clear, Laurel, we're currently doing both then. So a yes vote would be status quo.
Yes.
Well, and I think the question you asked is pretty relevant because I think the 401 stuff, Percy stuff goes into a better investment. Usually you get a little more interest off of versus what Social Security, which is extremely risky and yeah, but don't take it away until I get there.
Well, oh, come on, man, that's selfish. So one more clarifying then. So with the way Percy's structured, if they voted to not participate in Social Security, can that money go into Percy or does it have to go into some other 401k? So can we like double up on Percy if they vote?
So there's
No.
two parts. So there's, and I'm going to use the wrong terminology because I really wish a Percy expert was here on this part, but there's the regular mandatory Percy plan that as a public employer, you guys are paying into, right? Where it is set in statute how much each the employer has to pay in versus the employee. So that, I'm gonna say bucket of Percy does not get changed. You cannot add more to that bucket. Percy has other vehicles that you can use, which would be like their whatever the number is, 401k or 457 plan or something like that. And so Percy is the one who is managing that, but it's not part of that. Percy is, on a regular level, if that makes sense.
And at the county level, we do both as well for all of our employees. I have a Percy account and then a separate Percy account each month that part of my salary goes into, and then I also pay Social Security as well. When I get my check, it's like I owe them money.
But the 401k plan is called Percy Choice. So it's a choice of the employee whether they contribute to that or not. So that's
I
the,
could not think of what the
Yeah.
term was. I appreciate
but
that.
like I said, it's managed under Percy, but it's not part of the defined benefit plan. It's not part of the pension. So that's where the, yeah, the social security portion that the employer is putting in for each employee, could that dollar amount that Cronin will determine, certainly you'll have it before we make that, the board makes that decision. That would be contributed to the choice plan as one of the vehicles, not the defined benefit plan.
So then we could determine that in lieu of your social security, the district will contribute to the choice plan. And the choice plan is managed by the same individuals that are managing the defined benefits. And Idaho has one of the most solvent retirement plans in the country and one of the greatest returns. So that seems like it would be an attractive offer to just switch them from social security to the choice portion then of Percy.
Yeah, I think personally, I like that idea as well, but I think it's an employee choice.
Mhm.
Thus the vote, and we'll see what the vote comes back. Yeah,
But
as Jackie said, it's 51%.
if we're front loading information and saying, well, here's your choice to choose choice. Or then what other options would we then be required to set up some sort of 401k outside of the Percy?
But there
umbrella.
would be action that needed to happen, just administratively working with Percy, that when all of this change were to take place, that those funds go to the correct accounts, setting all of that up, which we would need to get Percy involved for that portion to do that.
But I think if I'm re-ask the question, so if they didn't want to be part of Percy at all, and or is Percy and Percy Choice the only other option, or is there some sort of Vanguard 401k or Charles Schwab 401k or something that would be another option outside of the Percy umbrella?
So that really would be up to you guys to explore if there were other avenues that you wanted to go down. There's the deferred compensation plan, the 457. I'm trying to remember who the vendor is on that. That's also something that the state provides. But when it comes to those funds, really, it is up to you guys to decide if there's other avenues that you want to explore or if there's other options available. It's not something that's dictated in law whatsoever. So it's your budget. You get to decide how you want those funds to go. I have not seen anyone go other than Percy during these, but that doesn't mean that you can't. It's your funds. You get to decide how that
Or
works.
reinvent the wheel?
Well, and I think the question is, on the charging part of it, we know we have to do the mandatory 401. But the choice stuff, it may be a decision that the employees may want that money back in their salary, and they can go invest it where they want to.
So that then is also an option.
Laurel, who does payroll? Is this gonna cause a lot of work for somebody to just do all this down the road?
We internally process payroll as people submit their timesheets, and then Luma, the SCO issues are paid to us. So no, administratively, it would just be a change that we'd make through Luma.
Through Luma.
Yeah, our receiving the paychecks would happen the same way that they do now.
Sure.
So if, as the department, we're contributing 7.5% or whatever the percent is now, and then it comes out of theirs, are we talking about making a decision for 15% that they could then make a choice about, or are we just talking about this 7.5% that,
You're only talking about the employer share of the funds.
And I'm assuming
so
if
what happens to the,
if we budget for it and then we
Get their
don't,
paycheck. They would get it in their, they would,
paycheck.
they would keep it in their paycheck. They're
it
not,
just wouldn't be so.
So it wouldn't be
if it would go to social security, it would go into their bank account.
and our match that we had budgeted, that match would probably just go as cash carry over token expense.
So if they opt not, then they would have funds, doesn't count towards your orders towards retirement if you're not payable. Plus, you would end up paying more income tax on it.
Right. That's right.
Right. Mr. Chair, if I may, I trust that the employees will be well educated on the various scenarios that they're going to be confronted with.
Yes, so we have, Jackie and Rachel have already come for 2 high-level information sessions. We have the 3 full information sessions, which I will send the invites to the board. You guys are voting too. I did not send those invites when we initially sent them out to our employees. They're 2.5-hour sessions, so SCO will be here, Percy will be here. Social Security will be participating as well for the more really in-depth level of questions. They're happening end of May and beginning of June. There will be a virtual option, but you're all welcome to attend in person as well.
Thank you.
Okay, but is there any more questions on this? I just had a kind of an off the agenda question for Laurel, or maybe it's for Rachel, I'm not sure. How do you guys treat leap year as far as payroll? Did you count an extra day or the extra hours, or how is that handled? Because we ran into a huge wreck on the county level.
I don't know that it's been any different. It was just a part of that payroll. I guess it's one extra day in the payroll year, but,
I can maybe help a little bit just from working at the controller's office. So leap year is normally not an issue for us because we're paid on a bi-weekly, but every 11 years, there's an extra payroll cycle, and that is the one that everyone talks about. But otherwise, just the leap day, that's just part of the regular payroll cycle, so
Part
that
of the
does not.
If you're paying on a monthly basis, it's hard to figure out what those hours are, and that's where counties are running into kind of a crash.
So for us, where it's just a 2-week cycle, that just keeps going and going until that 11 year, and then everybody talks about it.
Mr. Chair?
Yep.
This board knows about the 27th pay period because we are preparing for that and we're building our fund with carryover funds. So each year we contribute to that so that we're not having an extra pay period without the funding to do that when we get there every 11 years.
Okay. Hey, Crystal, welcome. Crystal, we're at the point in our agenda talking about the Social Security coverage, and I'm gonna try and addendum this, but basically it's a kind of a survey of the employees of how they want to see whether they want to continue in Percy and Social Security, or pull out Social Security and put that money somewhere else in their wages or in another 401k. And maybe you can help me out here, Jackie. We're gonna have a vote here sometime.
In the next little bit. So voting period will begin April 1st, and then most likely we'll be holding the vote in September to account for military deployments, but all eligible employees, so someone who contributes to Percy, and it's an employment relationship, will participate in the vote, so that will include board members. They'll decide at that time whether they want to participate in Social Security.
You good?
Yes.
Okay, well, thank you very much, Jackie. Appreciate all the help, and I think we got our heads around it now.
I'm happy to answer any questions about my.
And are you on this?
I'm on over your flyer.
Oh, good. Yeah. Okay, thanks, you guys. Have a great day. We're gonna move on down. Our next agenda item. This is a review. This is not an action item. This is a review and discuss opioid settlement funds. Courtney, are you here?
Yeah,
Good to see you again.
you too.
I was amazed by the amount of money you guys have gotten, a lot more than the counties have.
That is correct.
Oh,
We
So-
did receive several lump sum payments that were meant to last for several years at a time.
Okay, so I'll turn it over to you.
Thank you. So my name is Courtney. I'm the Substance Use Program Manager at Central District Health. I'm here today to go through a recap of how we spent our opioid settlement funds last year and give you an idea of how we're going to spend our opioid settlement funds this year and our trajectory starting into fiscal year 2025. Next slide, if you would, Destin. So as you can see for the first slide, we have quite a bit of funds, as I'll mention, that came in through the central to Central District Health. So we received $1,587,137.94. Last year, we spent $61,437.86. Most of that was on personnel, and we'll discuss that. So that left us with a balance of $1,527,700.08. Most of those payments were from the payment that we received in October of 2022 last year. So that was the bulk sum that we received, in addition to other settlements that were received prior to that. And we have received new settlement funds, since then. Next slide.
Courtney, before you move on, do you remember what pharmacies most of this money came from?
Probably a Conan question. I don't recall. I just know it was quite a few. I believe we had Walgreens, CVS.
And Rite Aid does not pay, they declared bankruptcy, is that correct?
Yes, they did.
Yeah.
So I know those were two of them, CVS, Walgreens. Those are the two that are coming to my mind, but I can't recall the other two.
Thank you.
Yeah. So for expenditures, you can see in your packet, so you have the slides in addition to Exhibit A. So Exhibit A shows all of our allowable activities. The activities that are highlighted are the ones that Central District Health worked on within this last year. We do anticipate that that's going to change quite a bit this next year when we're looking at how funds were spent and what activities they were worked on, because we had some personnel that was supporting the Valley County Opioid Response Project, and they were working on several activities that will be under a new grant, not under opioid settlement funds. So those activities will continue, they just won't be under this funding source. So there's three main buckets that I'm going to address. The first one is Section J. That is $22,000 out of the $61,000 that was paid for using personnel. So that pays for my time as the supervisor, Curtis's time as the division administrator, Becca, who is our health policy and promotion program manager, some examples of where those funds went. The second largest bucket went to our clinicians. We have 3 clinicians at Central District Health that all worked on our medication for opioid use disorder implementation project. We'll talk a little bit about that in the next couple of slides, but that went to predominantly their time. So Section A is for the treatment of opioid use disorder. And then Section G is our second or the third highest, and that is related to the prevention of misuse and use of opioid overdose or opioids. So that went to activities that were aligning really well with the drug overdose prevention program here at Central District Health. Any questions about action?
On the clinicians, does that include the MAPT ability, medical assistance
Yeah.
technique or something like that?
Yeah, so medicated or medication-assisted treatment is a part of medication for opioid use disorder. The way that Central District Health has done that has been a low-barrier buprenorphine model, and we'll talk a little bit about what that looks like.
Okay.
Next slide, if you would, Dustin. So highlights, so we hired the substance use program manager within health policy and promotion. So that was my position. Previously, I was in the drug overdose prevention program. I've been with CDH since October of 2019. This role is responsible for overseeing the opioid settlement funds allocation in addition to the substance use programming staff that we have. So we're a small but mighty team of 4. It's myself, Connor Young, who is our health policy analyst. He does our behavioral health coordination pieces in addition to opioid settlement fund activities. Heather Allen, who does our early childhood prevention, youth alcohol substance use prevention program, and she also does the new grant that came into Boise County, the NACHO grant, the grant that does healthy outcomes for positive experiences, so addressing early childhood adverse experiences. And then we also have Jessica Harris. She's a licensed counselor, and she does our drug overdose prevention program in addition to Project Provide. So we have 3 different funding streams that are available through ARPA, several funding streams supporting prevention work, and then ongoing recovery support and treatment work. So we've got most of the continuum of substance use addressed in our current activities. During fiscal year 2023, we had a total of 11 staff members coding time to opioid settlement funds. They worked a collective 923.1 hours with a salary and benefits expenditure of $44,200.06. We had very minimal operating expenses in our first operating year. We had $93 that was spent towards general office expenditures, $100 for cell phones and communications, so printing costs, and then $921 designated for travel and training expenses. That was including leadership training for myself. Next slide. Other highlights, and what we're most proud about is that CDH initiated a collaborative project between the Health Policy and Promotion section and Family and Clinic Services section at Central District Health. So we crossed over divisions to leverage our resources and support our staff. And that was aimed at the successful implementation of our medication for opioid use disorder project. So that was that. Clinicians were educated on how to prescribe and how to do induction appointments and maintenance appointments on buprenorphine. Buprenorphine is one of the 3 medications that is FDA approved to treat opioid use disorder. We recognize that that service is able to happen in primary care clinics, so that expanded our clinic capacity to be able to educate our clinicians effectively on how to prescribe those valuable medications. To do that, we hired Dr. Rada. She's a medication for opioid use disorder consultant. She worked with us for 22 hours on the project up until that point, but has continued to provide support to our staff, providing that one-on-one education with the clinicians. So that was a pretty great opportunity for us. Next slide. Thank you. We also developed a visual care model. So we wanted to figure out, how does buprenorphine prescribing fit into our primary care clinic model? So we did a patient flow through phases of buprenorphine treatment visual guide that kind of talks about the roles of what that will look like for us. We did aim to adapt a low barrier buprenorphine model. The evidence has been really successful that in primary care settings, that's the way to go. That helps remove obstacles to treatment that has been shown to reduce mortality rates, HIV risk behaviors, and incidence of hepatitis C and HIV. Those principles of the low barrier buprenorphine program is that it's based on same-day treatment entry and medication access. So how we can reduce the time and effort the patients spent getting to their appointments, accessing care, and then accessing medications as their follow-up. Having a risk reduction approach or harm reduction approach, and then flexibility and wide availability where people with opioid use disorder go. And we recognize that we were already treating patients with substance use disorder, just not as effectively as we could be. And this allows us to expand our capacity in that way. So it is adapted, due to our pharmacy limitations. So our pharmacy does not currently house controlled substances on site. But we'll talk a little bit about what that's going to look like in this next fiscal year and how we're going to get around it. Next slide. The biggest lift for the MOUD implementation project was doing a prescribing guidelines. So this was everything clinical that the providers needed to know in order to safely prescribe, screen, evaluate, treat, and assess an individual for opioid use disorder. So that essentially started by having a conversation from the clinicians, in addition to our medication opioid use disorder consultant, Dr. Rada, as to what they wanted to see from that. So we came to the principles of having harm reduction principles on dignity, respect, and non-judgmental care as the foundation for the prescribing guidelines. And then having it be subject matter led, medical director led, and provider supported, with the goal of meeting each person where they're at, providing support and interventions that align with their goals. And then we worked with the clinic manager to align the clinician schedules to have them visit with a medication for opioid use disorder consultant. So they were available for those one-on-one education sessions. Next slide. So this probably looks really similar to what you guys saw in December of 2022. We have since changed this. We were initially discussing doing methadone. We're no longer going to do methadone because that would require us to be an opioid treatment program through SAMHSA, and that was too many barriers. So the medications we've decided to go on for medication for opioid use disorder include naloxone. So Narcan, the 4 milligram over-the-counter medication that reverses opioid overdoses, is provided to all patients who come into Central District Health with a substance use disorder or opioid use disorder. We also have buprenorphine. The target audience for that is for pregnant women. So that's a sliding scale for 12 to 24 milligrams of medication. We haven't had anybody on exclusively buprenorphine yet, but we anticipate that that will be a need that we'll see in the future. Buprenorphine naloxone is our standard practice of care. So that is what the only patient that we currently have right now is on. That medication is our priority medication for the rest of the populations that are no longer pregnant or non-pregnant. Again, a sliding scale of 12 to 24 milligrams. Initially, the plan was to house those medications on site, but we're going to be working with community-based partners to have those medications be housed through their pharmacies, and then be working with them either on a contractual basis or we purchase the medications and give them to them to have our patients pick up those medications. So it still is doing an adaptive low barrier model. It just works better with our pharmacy and how it's structured. And then the last series of medications are all available by prescription or over the counter. So these are over the counter medications or medications that are addressing acute opioid withdrawal. So when people start buprenorphine, it's common that they are in mild to moderate withdrawal, and that can be a pretty miserable experience for folks. So there's medications that can offset that while they are starting on medications. So there's trazodone, which is used for sleep, Entyl, which is used for stomach cramps, Vistrol, which is used for anxiety, Bismuth, which is essentially Pepto-Bismol. And then for folks that have alcohol use disorder or a history of hypertension, there's an additional screening that comes into play with that, and they can also be prescribed clonidine. Our initial plan was to purchase those medications on site, have them prepackaged and ready for patients. But again, we're going to be moving towards the community-based pharmacy model instead. Next slide. So this gives a little bit of an example of what that looks like for a patient experience. Our patients are going to be seeing us on a weekly basis to get started on medication for opioid use disorder. So they'll be visiting with clinicians once a week for the first 4 weeks. Between week 5 and week 8, they'll have biweekly appointments. And then starting at week 9 is when they're considered to be in maintenance mode. And that means that they're stabilized on those medications and at their final dose. And then they will visit with us on a monthly basis after that. So from induction, which is those initial appointments, to maintenance, they're going to have a minimum of 7 appointments with the staff. And that can be increased at the provider's discretion or at the need of the patient, which one comes first. Next slide. So we also did have a training, which was screening and brief intervention or referral to treatment. That's SBIRT. It's an evidence-based reimbursable practice for clinicians. We had a training that was on that provided to us through Ada County funding. The clinicians were trained on that in addition to some of our medical staff. And that since then has been integrated into our electronic medical record system. So we have SBIRT as our screening and diagnostic tool for folks who are on opioid use disorder. So we will have that be a part of the regular patient experience. We also are going to continue to look forward to having more safe space inductions. So when we're talking about safe space inductions, that would be safe spaces where patients go. So if that is at the shelter, a family member or friend's house, or their own personal residence, they would start medications in that space rather than starting them at Central District Health when the time period is right for them. And then transitioning patients into the maintenance phase of their treatment, which is again over 9 weeks or more. We also implemented a brief recovery capital assessment, which is a pretty unique tool. This tool looks at the recovery resources that an individual has and leverages those resources. So that could be having strong family connections, that could be having a stable place of employment, that could be support through their employer, things that are going to help that individual manage a lifelong chronic disease, and then reframing that from a strength-based approach for how they can use those resources to manage getting started on opioid use disorder medications. We're going to continue to explore our pharmacy capabilities and funding to fully implement a low barrier buprenorphine treatment. So that will either be at low cost or no cost to the patient. We're looking at having reimbursable expenses up to a set amount that will be for patients that are no longer covered under or not covered under medical insurance, or have medical insurance that isn't covering their cost of their medical appointments to the point where it's cost prohibitive for that client. We're also going to be doing a media campaign. We're excited about that. We're currently working with Pepper Shock. We haven't done a media campaign like this before at Central District Health. So this is going to be advertising our clinic capabilities, but also letting people know that recovery is possible through the use of buprenorphine. So that is going to be selective messaging that we're going to be doing in bars and restaurants in addition to radio advertisements. So that's a few of the projects that we're looking forward to and the things that we're currently working on. Mostly what we're doing is we're using Exhibit A to kind of guide our activities, recognizing gaps and needs in our community, and then using evidence-informed decisions to guide our future work. So when we get to the last few slides, you'll see what that looks like. Next slide. So these are upcoming projects. These are things that we're currently working on and things that we're going to be working on into or through this fiscal year and then into next fiscal year. The first one is what we call Barney boxes. That's the purple box that you can see on your slides. Those are naloxone newspaper boxes. Those are very popular because they're low barrier methods for distributing out naloxone to folks. We already have 3 clinics that are guaranteed to get those set up for us. They're called Barney boxes because they're the color purple, but purple is the color for International Overdose Awareness Day, which is every year, August 31st. Typically, the Drug Overdose Prevention Program does an activity for that, so that allows us to, on an annual basis, let people know, again, that the community is available for free naloxone distribution. There's 2 things that happen on the newspaper box. The top one will educate people on how to address and assess for an opioid overdose and the steps that they need to take, including the administration of the Narcan that's inside the box. And then the second part talks about dangers of counterfeit pills and having fentanyl in counterfeit pills, because 7 out of every 10 pill that was seized by the DEA has a lethal dose of fentanyl in it. So there's a lot of education in a short period of time that's happening in these boxes. And then the goal is to have them in clinic settings, or in community-based settings, so people can continue that conversation with the right resources. The next thing that we're also going to be looking at doing is public health vending machines. We'll talk about the contents that could be in those vending machines on the next slide. Again, it's just a low barrier method of being able to distribute supplies, tools, and resources to folks. It doesn't require the same interventions or staffing that education typically is associated with. We're going to be continuing ongoing clinical education of hepatitis C to our 3 CDH clinicians. There's a free resource available for the University of Washington on hepatitis C treatments, medications, and services, and they're going to continue to take those modules. And most importantly, we're going to be doing an environmental scan or a capacity assessment. So this will be looking at all the opioid settlement funds that have been funneled into Central District Health, our cities and counties, and what constitutes our jurisdiction, to look at community gaps and needs and figure out how that funding is being utilized from those agencies, so we're not duplicating our work and that we can make sure to leverage our resources appropriately. And then having recommended strategies for regional needs, so addressing our 4 counties appropriately. Using those opioid settlement funds. Next slide. So these are some items that could go into the public health vending machines. It's just an example of how we intend to use them and how it would be a blended project that would be from multiple funding streams. So the sun safety kits, those are through our cancer prevention program. We have Deterra drug deactivation pouches, which are through our drug overdose prevention program, and prescription lock pouches. The Deterra drug deactivation pouches are particularly important for rural communities or people who are on septic systems, because we don't want people to flush their medications. So there are these little tiny bags that people put pills, patches, liquid medications into, add a little bit of hot water, zip it up like a Ziploc bag, and then they toss it right in the trash. So it's convenient and it's environmentally friendly. So at least for the Deterra drug deactivation pouches, we would be prioritizing those in our rural communities first. The prescription lock boxes are a means of reducing medication diversion. So you have to fit those boxes in the vending machine, but we have smaller size pouches that are a 3-code pouch. So folks can fit their individual medications in there, lock it up with the code that they select, and then nobody else can access those medications. We also have face shields and rescue masks. Those are used in overdose response. So it would be an important part to distribute that with the Narcan, the 4 milligram Narcan. And then we're also going to be doing sharps containers. We could also do condoms, dental dams, or lube that's provided through CDH's sexual health educators, and then dental kits that are offered by the CDH oral health programs. So those are some examples of the diversity of items that can go on the public health vending machines. The cool thing is that the schematics can be updated as often as we need to when we work with an organization that provides those vending machines. So we can fit them to have seasonal items or larger items, or reduce them based on whatever is most popular, so that we're prioritizing what people are looking for when they're coming to those vending machines. And those would be one-time transaction vending machines, so we're not counting it by person. It would be counting it by resource. So in theory, one person could go there and get a vending machine, or go to the vending machine, get some Narcan, next transaction, and get another face mask, next transaction to Terra, that kind of stuff. So we won't know the amount of people necessarily, but we will know the transaction base that it has, which is pretty exciting stuff. The next couple of slides are for your own review. It's essentially just showing how Central District Health is using Exhibit A and using our allowable activities to be able to fund these different projects. When we were looking at the public health vending machines and the naloxone newspaper boxes, this is where the evidence came into. So the drug overdose prevention program does overdose rescue training. So we teach people how to prevent, recognize, and respond to an opioid overdose. So when conjunction with naloxone distribution, that's considered an overdose education and naloxone distribution program, which has been proven to improve patients' attitudes regarding opioid overdose, regarding naloxone as well, and then providing sufficient training for participants to safely and effectively manage overdoses. That's particularly important in our rural communities because there's a longer response time for EMS, and we need community-based bystanders to be aware and trained on how to administer Narcan in case an event happens. And then it effectively reduces opioid-related mortality, which is particularly important here in Ada County because we have the highest rate of overdoses in comparison to the rest of the state. So the next two slides you can review at your own leisure. We will continue to revise some of the projects that we're doing, but that gives you an idea of what we're working on currently and our directory for where we're going to be spending our funds in the future. That's all I have for you today.
Courtney, that was awesome. Go ahead.
Mr. Chair and Courtney, could you tell me if we're primarily the opioids we're talking about here, maybe fentanyl rises to the top with the naloxone. We are seeing Rompin or animal tranquilizers come into that are much more deadly than the fentanyl, and naloxone has no effect on them. Are you
Correct.
working in those areas?
Minorly. So as you can see on the last couple of slides, when we were looking at the contents for the vending machines, the fentanyl testing strips law just passed. And so that is legal. That will go into effect July 1st. So we can put fentanyl testing strips in the public health vending machine. Xylazine, that animal tranquilizer that you were talking about, that one is not legal. So xylazine testing strips are not a part of that current law. So we're educating folks on xylazine and letting them know to be aware of that. We know that it's in our current drug supply.
Right.
We know that people who have had access to xylazine testing strips that are patients in accessing those substances are reporting that it's in their drug supply, but we don't know how widespread or prevalent it is. So we're trying to catch the curve before it hits us.
And I guess it's very cheap to produce.
Very cheap,
Very cheap.
yes.
Courtney, I have a bunch of questions. First of all, what is the correlation between opioid and hepatitis C?
Hepatitis C is contracted through intravenous drug use from needles, sharing needles predominantly. So there was the intersection between having an individual with substance use, their mode of administration, and then their risky behavior. So if they continue to engage in substance use, particularly sharing syringes with other people, it increases their risk of hepatitis C contraction.
The next question, the purple boxes, are those pretty spendy? I mean,
They are $600 a box. Yeah, but
without
once you
anything in them, just the boxes.
just the box, just to get them to the door is $600. And those are paid for using opioid settlement funds. We've ordered 11 of them already. We've got 6 of them on reserve, and then 5 of them we're pitching to community partners to see if they'll house them. The best part is that once you buy them, they stay forever. I mean, I think we can all see Boise Weekly boxes or the Boise Realtor boxes. Those ones stay in places like Albertsons and pharmacies. They stay there for forever once they're installed. So it's a one-time investment that's a little spendy that's going to last for a long time.
So what is your plan as far as the rural communities in our district? Are they gonna get,
Oh, absolutely. I'd like to get out as many as I can.
maybe down the road, you could kind of provide us a list of what you're thinking of, and then we can look at it and say, maybe you ought to think about this, or I know in our case, about County, we have a medication take back that's at the sheriff's office. And it's pretty widely used. But my next question was, I know, maybe I need to ask the doctors, just a couple, 3 years ago, there was some talk about limiting how much a prescriber could prescribe hydrocodone to like 5 pills or something like that. Did that ever happen? Is that the case?
Describe those, so I don't.
So the CDC has a series of recommendations that is on opioid milligram equivalents. And the recommendation is not to exceed past a certain threshold without having other conditions being met. They have an app for it. They have trainings on it quite constantly. There is little regulation to that past best practice recommendation. So that would have to go through the Board of Pharmacy for them to determine. We have seen overall a decrease in the morphine milligram equivalents that have been in our jurisdiction. So across the board in Central District Health's footprint, we're seeing less opioids prescriptions. We are seeing them higher in rural communities than we're seeing in Ada County, but that makes sense based on the number of practitioners prescribing in Ada County.
Does that include the dental part of it as well?
It includes anybody who would prescribe opioids. So
Anybody
that could include veterinarians, that could include people who work at dental clinics, people in surgery, people that are on long-term pain management. It includes everybody.
And then the last question on all that, anybody else, we have kind of a different issue up in Valley County. A lot of our folks are retired, elderly, older folks that rely a lot on pain medications. The issue we're having is that if one of them ends up going into the emergency room through your paramedics or EMS, we were hoping that we could get some kind of cooperation with EMS, that they would go in and take those pills and bring them with that patient, because they can't do that now. So they're leaving them at home while grandma goes to the hospital. And people find out about it, break into the house, whether it's a relative or a neighbor, and steal those pills. Is there any way that we can work to get something like that pushed through so that EMS has the authority to go in and bring those pills with that patient?
I think that would have to go through the EMS board before going
Okay.
through a local jurisdiction like Central District Health. But I go back to the root cause. So if those medications were locked up appropriately and stored safely, then those medications wouldn't be a temptation to people who would be looking at diverting that for their own personal use. So I think what we can do is having Deterra drug deactivation pouches and prescription lock boxes be widely available up in Valley County.
Is that something that you can take home and lock it up at home?
Yeah, so they're like little mini briefcases. So
Oh,
people
okay.
can put their medications in there. They choose the 3 code that they want. It can even be 1, 2, 3, who's gonna know? And then they lock up all their medications in there, and then they are the only ones that have access to it in theory after that. And then if the Deterra gets rid of any medications that are no longer needed or no longer wanted. So rather than having them to go to the police station to drop off their medications or doing the annual drug take back day, they can just dispose of them whenever
And
the
pouch,
occasion
the
arises.
Right.
Exactly. It's super easy.
I don't know about you guys, but when my parents were alive and grandparents, they had the table by their chair in the living room that was all their pills, and it's like, my gosh, if I was a little kid, that would be like heaven.
Yeah, and if you're a person with a substance use disorder,
Yeah.
that can be really difficult and triggering to be in those types of environments. So we certainly do educate people on those things. We often get called in after there's already been a problem, and people who report using substances, their initial route of trying drugs has been through family members and friends. About 65% of people report that. So we're trying to minimize that as much as possible. And that just comes along with a lot of education and a lot of resource distribution, so people have the choices made for them. So we'll continue to do the drug deactivation pouches and prescription lock boxes, but I'd be interested in knowing who makes the policy so the EMS could take those medications.
Well, even, normally in our case, if you call 911, there's a deputy that shows up first to make sure that it's actually needed call. And so even if we could get the sheriff's department that ability to go in and take all those meds, whether they're opioids or not, and bring them with that patient, I think it would solve a lot of our issues up there. The other thing I want to bring up is the opioid funds are kind of an annual deal. I mean, this money's going to be around for a long time. You know, and I'm hoping that Rite Aid ends up having to come up and stand up and pay the bill too, because we'll see what the bankruptcy does, but this is money that I think is going to be huge for, I've heard as long as 18 years in some of those settlements.
It's been the highlight of my career, to be
Yeah.
honest. It's not having the same degree of grant requirements that we're used to working with, that we have so much flexibility, and we really get to prioritize the communities that need it the most and use our subject matter expertise to find out what those gaps are and then make immediate interventions. And we don't have that flexibility like we do other funding sources, or with this funding sources in comparison to other funding sources. So it's life-changing money.
Yeah, definitely, especially juveniles.
Yes.
This is where we're seeing most of our issues up there is juveniles that have gotten a hold of grandma's medication. Any more questions?
I
Yep.
appreciate that you will provide us with specifics regarding what's being done in our county too, Courtney. Yeah.
Okay.
Thank you.
Go ahead.
When I saw this item on the agenda for today, I was struck with a measure of irony in that we spent the last 2 years censoring individuals, canceling individuals, threatening physicians that challenged a pharmaceutical narrative. All the while, we are receiving opioid settlement funds from the fraudulent marketing and bad behavior perpetrated by pharmaceutical companies and a dysfunctional regulatory process that allowed that to take place in the first place.
Right.
So had we had the companies that were submitting accurate, I guess for the opioid settlement, it came down to misrepresenting the likelihood of addiction and so forth. And so they were kind of frauding that research, submitting it to the regulatory authorities, and the regulatory authorities weren't regulating, they were capitulating. And then here we are in one environment, we're canceling people for questioning that while we're taking their money because of their bad behavior. And that is a little bit ironic that we're talking about this being the highlight of your career, this money, but we got to remember why we're receiving it. It's because these entities were committing the bad behavior that led us to this rampant addiction process. Purdue Pharma just they were in front of the Supreme Court a month or two ago in relationship to how much they were going to have to pay and whether or not the family assets, I believe, could be included in the settlement payments and the judgments and stuff like that. So if we kind of dial down to the roots, maybe we're seeing right here why some were justified in raising some questions about what we've been through for the last 2 to 3 years.
I wonder if we'll see kind of a similar situation with the coronavirus vaccine somewhere down the road.
Well,
Who knows?
I think we're already seeing evidence, and Dr. Cole, I'm certain, has an opinion on that, but I think we're already seeing evidence that we're probably going to be having someone sit across the table and say that the COVID vaccine settlements were the highlight of their career.
Yeah.
So this year brings me to my 10th year working in substance use prevention and intervention and treatment programming. I have predominantly worked in organizations that were grant funded and had very high restrictions associated with those funds. So when I say it's the highlight of my career, I'm saying it's the flexibility of the funds to really make a
You know, and I
difference.
get that, and I'm not rendering any opinion on what but just the circumstance that we're in, and I'm not in any way questioning what you're saying. It's going to be a similar situation down the road, and I'm not, critiquing you. It just happens that this is the circumstance that we're all in. And at the state level, we were talking about the opioid settlement money too. And there is that ultimate irony that on one hand, we're told we can't question a certain narrative, but on the other hand, we're taking their money.
Dr.
Roll.
Yeah, I'll second the irony comment, but I do have a couple of questions. Obviously, it's a societal problem, opioid overuse, and then with drugs still coming across the border and being laced and whatnot. What raw number of patients or percentage of the population are we looking at within our health districts? That'd be my question number one. So what do you see? I mean, most of these patients have to want to withdraw in order to enter these programs. So obviously the problem is probably bigger than those number that are willing to engage. So number one, that's my first question is, your either percentage of the population or raw numbers within our district. Second question is, how are you measuring your successes then? Is it absolute, I'm done with opioid totally, or the number of times of recidivism, et cetera? And the third thing, with buprenorphine and other medications, some drugs work for some people and others don't. I'm just wondering if the program has looked at some of the medical trials that are through NIH and through academic medical centers on the long-term success rates with medically supervised ketamine or medically supervised psilocybin, because some of the studies I've seen on that for long-term permanent non-desire to ever use opioids again have been incredibly successful as well. So that's my hustle of questions. Thank you.
Yeah, go ahead.
I'll try to remember all three parts.
Okay.
So part one, we're looking at a initial impact in Ada County because that's where our main clinic is available, but we're looking at doing advertisements to telemedicine to our rural communities. So we're looking at having anywhere from 5 patients a month that are on buprenorphine in the first year of the program fully being live. And after promotions have been set, that's our goal. So we would have 60 visits by the end of the year, and then a flexibility of up to 30 patients for opioid settlement funds contributing to cost of their medical expenses. So that's our initial footprint. I think that footprint will change when we have expanded to our rural communities and we are getting more of a traction. Places like Valley County don't have any medication for opioid use disorder available or MAT available like they used to have the Change Clinic. So we're anticipating that we're going to retrieve some of the patients that were previously a part of those institutions and have them be a part of CDH's patient population. So that's our first footprint. Second question, we're not measuring success by diversion or by lack of use or by prevention measures because it's really difficult to track that data. That's having conversations with people who use drugs, and our part of our funding is able to do that on a limited basis, but that would require a much more comprehensive plan that we just don't have the funds or time to do. I think that our environmental scan will give us a really good idea as to how we're being effective in terms of tracking our successes and the success of the drug overdose prevention program being a longstanding program prior to opioid settlement funds being available. So it's hard to know from the prevention aspect, but I think we'll track what is successful for us based on the number of patients that we have that are currently in maintenance mode for buprenorphine prescribing, the number of naloxone distributions that we gave out, and then the number of resources that we gave out for each person through our clinic and then through the outreach that we do. So I think that's how we would track that. And then part 3, we haven't looked into clinical trials into other things, mainly because we've been so focused on making sure that our clinicians have the capacity to be able to prescribe these medications effectively and all that it comes along with that. So I don't know if we even have the capabilities to, through our primary care clinic, that would be a question for county clinic services to do that.
Yeah, but it's just interesting to look at some of the other highly successful modalities that are evolving.
And the substance use disorder realm, even in the time period that I've worked in it, has changed dramatically. Our drug supply alone in Ada County and Boise and Elmore Valley County has changed so much over the last few years, just with the introduction of fentanyl. So I anticipate that we're going to continue to see resources funneled into research that's going to better understand how do we prevent substance use disorder from developing, and then how do we effectively treat the disease as it's been progressing in individuals. So I see where we're going.
Thank you for your good work and your
Yeah.
good presentation. We
Thank
appreciate it. Thank you.
Thank you. Appreciate it.
Yeah, Courtney, that was awesome. I know, right now, I think Ada County gives most of their opioid funds to the health district. Is that correct? Because I know,
Sure.
like in Valley County, we kept a large chunk that we wanted to kind of determine where we were going to spend that. And so we've set up V Corp and some of those issues up there, that the problem is that folks want to tie it into alcohol abuse or other substances. And you have to make sure you tie in opioids with it, or that funding had to be repaid.
Yes.
So you gotta be careful how you spend the money, so to speak. But, I think the next big crash we're gonna have to deal with is fentanyl. And we need to start thinking about how we're gonna get a hold of that one as well. That's a whole different bear.
It really is. It
Yes.
really is. And I think for us, so to answer your question, I know that the city of Boise has their own independent funds and the Ada County has their own independent funds. We went through using the Attorney General's reports to say who received funds and then did anybody spend them? And there were quite a few different locations within our jurisdiction where people didn't spend funds or underspent funds that were available to them.
Yeah.
So I think that's where our environmental scan is going to come in to get a better idea of who's got what money and where are they spending it, so that we're not spending money in the same places. And
Well, and how do you spend that money if you're not gonna spend it?
absolutely, yeah. And I've made myself available to anybody who has requested it, that we can provide technical assistance to them. It's not a punitive thing that they chose not to give their funds to Central District Health. We want to make sure that we're all doing the good work together. So for those situations, it's letting them know what we're spending our funds on, and then what ideas do they have for how they're going to spend their funds so that we're not duplicating that same.
Well, I think some of the counties build crisis centers.
Some of the Southwest District Health did use opioid settlement funds to do a teen crisis center.
Yes,
And I agree with your point. I think the fentanyl problem is just compounding. And I think letting the public know the number of drugs tested that are laced is so important. And I mean, with overdose deaths at all-time highs nationally, I think that's critical. Just kids that want to take that risk, or youths that want to experiment. I mean, you're literally playing Russian roulette at a 7 in 10 chance of a bad outcome.
and I think that's a great point. Our next agenda item is gonna talk about marketing and communications, and that was one of the things I want to bring up, is we need to get that information out to our high schools, junior highs. Crystal, you had a question?
Well, I was just you had a question about the prescriptions and limitations. And my mom just recently had a total reverse shoulder surgery, and I had to go pick up her medications. And even the pharmacist, there was an odd prescription that was usually reversed, as far as something that had Tylenol, didn't have Tylenol, and I don't even know what the names were. And they actually questioned me, and I said, I don't even know what those medications, I'm just picking up with the doctor. They actually had to call the doctor and say, hey, this isn't usually what is, prescribed. They allowed it, but so the pharmacies definitely are questioning.
Good.
And they had to go back to the doctor, and, it was a big, back and forth. And
I know in my case, I had a crown root canal thing done, and the dentist prescribed me 90 pills of hydrocodone. And I never took any. I took them home. That was the mistake I made. And about a year later, went to get one out for other injury, and it was empty. Someone had gotten into my medicine cabinet while using my bathroom and took all the pills at the bottom. And didn't even know what happened. So it can happen. Any more questions?
Yes, Mr. Chair, when we were at IAB this year,
Yep.
you will remember, it was pointed out, we had one of the Northwest law enforcement people that was trying to narrow it down to supplies coming in on certain highways. And he said what struck him was not just that, is a number of kids that are 5th, 6th, 7th grade coming home after school, sitting on the couch, parents are at work, sitting on the couch with their phone and ordering a cookie or candy and having it delivered to their best friend's house. It's laced with fentanyl.
And it was laced with fentanyl?
Yes, yes,
Oh my God.
yes.
You fix
So
that.
how do you fix that?
We do a lot of social media messaging on to parents when we do our Save the Family, which is what it's called, the Save My Family events, where people are made aware of what emojis are used in drug trafficking using social media sites like Instagram and Snapchat, things like that. That comes through the DEA that sees people's telephones, and then they see the same reoccurring emojis, and then they've started parent introduction or education to those topics since then.
I think
That's
Dr.
social
Full's right.
media.
It's just beginning.
Yeah.
It's just beginning.
I mean, for example, as fortunately known to, I received some box of powdered supplements from some company saying, if you're interested in this, and blah, blah, blah. I've never ordered it, never read it, read the letter, all sorts of misspellings. It looks like it's translated from a foreign language. Obviously, I disposed of it, but it's like, okay. I mean, and again, this goes to education, you know, especially educating the youth. Someone orders something and it shows up in your porch. Unless you have the King's poison taster before dinner. I mean, it's not a good idea.
Okay, Jake,
I just wanted to say excellent presentation and thank you for representing us.
Thank you.
okay.
I did have a question on the location of the Barney boxes and the vending machines.
Love to get one.
Well, just, I'm thinking about places in Boise County specifically that would be willing to.
Yeah, we talked about it to Idaho City. We were in Idaho City last week and visited, I think it's ICAB, the Idaho City Ambulance Bureau.
Yeah.
Yeah, we talked to them about it. They are interested in one. So I think we need to just develop a better partnership with them and actually get the boxes to our facility, and then we'll figure out how heavy they are and what that means to move it, and then we'll go.
I was just wondering how many, like, you know, there's just Boise County spread so far to get one here, one there.
Also thought about the Medigap pharmacy, if they would be willing to do it, because they've done prescription lock boxes and Deterra drug deactivation pouches for us before.
So real quick on those Barney boxes, in terms of where you locate them, obviously you would want to locate them where you track most of your overdose areas. I mean, is it naloxone for anyone that needs it? Is it open? Do you have to have a code to get into it? Is there, so yeah, I guess it's wherever the biggest problem is in each county is where it makes sense to.
If I may, the problem with Boise County in particular is that there is very little data collection that we have successfully coming out of Boise County. There's no emergency rooms there, so we can't use emergency room data to do essence data. There's nobody currently into ODMAP or who is recognizing overdose events through ODMAP. That would be through the ambulance agencies that would be eligible for that. And then most of the time, if somebody has an overdose event and they're transferred to Ada County and they pass away in Ada County, it counts towards Ada County's data, so it doesn't count towards Boise County. And we don't have a relationship with the coroners to have an MOU in place so that we could collect that data from them when they have eventually those participants that do pass away from overdose that are from Boise County. So we have no idea the scope of the problem. We have really good direction, and we have anecdotal information, and we have partnerships with community members that have informed our work in that area. But in terms of concrete hard data, it's not very succinct.
Would there be any hesitancy to use it in certain communities? I mean, would a person that goes up to get something out of a box be stigmatized or judged by someone else that witnesses them? Is there the possibility that someone's going to say, well, he must be a crackhead. He's hanging out at one of the purple boxes.
If I may.
Yes.
I think it depends on where we place those boxes. So having them be in places where people would already be involved in similar activities. So perfect example would be up in Valley County, having it at the McCall Police Department, right next to their medication disposal box. So people are dropping things off, picking things up. And then it's going to be a responsibility of us and the Drug Overdose Prevention Program to continue the education that naloxone is for anyone. So I'm thinking about your mother and was she prescribed opioids, and was she also prescribed Narcan? Because if she wasn't, she should have been. That's good prescribing practices, having both of those available. Yeah. So having Narcan widely accessible to people, that's the goal because you can't administer Narcan to yourself when you're unresponsive because of a drug overdose. So we need other people around us to be able to administer it to us.
So the purple boxes are only Narcan.
Only Narcan for right now, but there's the capability of also doing overdose rescue shields in there. So having a mask for rescue breaths and then having the Narcan itself.
So then how about with the vending machines?
That's where it's it's goodies galore. Like,
Right.
yeah, lots of options there.
You bring up an interesting point. I think, Courtney, the fact that we talked about this at IAB 3 or 4 years ago, the disconnect between coroners and the statistics. And in our case, a lot of folks in Valley County, like I said, are elderly that pass away. They're listed as natural causes when in fact they were an overdose issue. So the coroners aren't really given free rein to share that information. And it may be something we might want to talk about for IAB down the road. Some kind of a reporting system on those so that we know that we got a more serious problem than I think we need.
And it's interesting historically because the coroner system comes from the Crown system of England for death taxes. But if you look at states with medical examiners versus coroner systems, the data collection tends to be better. So like in Utah, they have the Central Medical Examiner's Office in Salt Lake, and all the cases come from around the state that you can track better. So that would even have to be a legislative thing.
Yeah, it would be.
Change in the state level to a medical examiner system over.
But that's where it started as a group like, IAB, where we all get together and say, hey, we need this data.
But it's important to know. I mean, how do you address a problem if you don't know where it is?
I know as a county, we spend a lot of money every month on toxicology for people that have passed away. We don't see the results. We just pay the toxicologist. And you can't get those results. And it's like, it's not that we're trying to defame the family name, but it would be nice to know if we have an issue in our elderly, especially, that they're accidentally killing themselves. Okay, Dr. Furman.
One last tidbit on opioid addiction. Obviously, one of the best treatments is prevention, right? And so depending on how you look at the numbers, it can be up to about 25% of opioid addictions start from a legit pharmaceutical prescription that then ultimately leads. Obviously Rush Limbaugh or somebody famous, that can entrap a lot of people. And, in the legislature, this is where we are supposed to declare our conflict. But educating people about non-pharmaceutical treatment regimens that avoid the entirety of the opioid pathway can be a great adjunct to this problem. We see that a lot in the VA and so forth. Taking shorter, quicker pharmaceutical paths that then lead to 25% of the addictions start from a pharmaceutical opioid prescription, where maybe that could have been avoided if we were emphasizing more conservative, non-pharmaceutical clinical regimens prior to even being involved in that environment.
Yeah, I agree. I think sometimes they're a little overprescribed.
And
Any more questions or comments?
I think too, that we're dealing with a lot more of our adolescent experimentation leading to adult lifestyle in our parents.
Okay, everybody good? Thank you very much, Courtney. Appreciate it. And we'll be looking forward to the data, where you're kind of going to put them, and we'll help you, I'm sure,
I'll
with
give
that.
you a whole beautiful map next year just to be.
Good, thank you, thank you.
Before we move on, does anyone need a break? Okay, so let's take a 5-minute break, and because I need one too, and then we'll come back.
Good call.
Okay, welcome back, everybody. We're at our 9:35 agenda item. This is a review and discuss the marketing and communications. Maria, welcome. Good to see you. I'm going to turn it over to you. I have lots of suggestions.
Dustin, if you can share the presentation. Thank you for letting us, the whole team can present today. Next slide, please. I'm Maria Ortega, I'm the Marketing and Communications Manager, and Zach and Trent are also going to be presenting after me. And I want to start by saying that our program's mission is to empower individuals and communities with accurate, accessible, and timely information about the services and programs here at CDH. Next slide. And so we do these through three main efforts. One is PIO media relations, internal communications, and then marketing, which includes branding, social media, and website. So the presentation today is a summary of the calendar year 2023 efforts and results that we did. Next slide. So in the media relations arena, we do some news releases, we pitch reporters specific stories, we facilitate media requests that we get directly from the local media, as well as the public record requests. And for 2023, that resulted in 89 published stories total, with the majority of them being positive stories, covering our programs and letting the community know what we do and educating them in different aspects of medical diseases or programs. If you want to see the actual news releases that we sent, which you get on your email, you can also scan that QR code and you can review them.
Quick question before you go on. The public information requests, can you give us a really quick rundown of what those requests were about?
Mainly these last few months were requesting information about the complaints that employees share with the United States Monthly. They were asking for.
Most of those.
Yeah.
Thank you.
Yeah. Next slide, Dustin. And we also track who covers what. And you can see that KTVB and Idaho Capital Sun are the two top local media mentioning CDH. But I wanted to highlight number 7 and thank our bilingual staff who have been willing to go be interviewed early in the morning, I might say, and talk about our programs, but also the fantastic outreach efforts that they do trying to reach out and educate Spanish language speakers in our community. Next slide. Moving to marketing efforts, we strategically promote health and wellness initiatives through marketing campaigns, collateral material, and various social media platforms. The goal here is to cultivate strong brand awareness, drive participation in the programs and services, and ultimately improve the health and the health outcomes of the individuals in the communities we serve. So this year, we have run 14 different marketing campaigns, and we developed 4 new brochures. And I divided them in family and clinic services. They have 5 campaigns and 1 brochure. The community communication outreach program, 1 campaign and 3 brochures, and the health policy and promotion programs, 8 campaigns. Next slide. Most of the campaigns have different strategies and platforms we use depending on their goals, target audience, where they live and how they behave. But they range from radio ads, billboards, print ads, social media, online ads. And for the sake of time, I'm not going to go through every slide in detail. You have the packages with you. But I want to bring attention to, for the non-marketing people in the room, to the bottom area where I explain what impressions, clicks, and conversions are. And conversions are when you see an ad online on Facebook and you don't click on the ad, but then a week later you remember the ad and you're like, I'm gonna learn more. That's the kind of behavior that we want. That means that people remember the message, remember who we are, and they actually Google us or find our website and learn more about that program or service. So I just wanted you to understand what that is.
So it's like a first look ad. Kind of a first look ad, more of an eye catch kind of a thing.
No, it's kind of you've seen the ad so many times that it finally kind of you remember that messaging. So the impression is how many people see the ads. Sorry, I'm old and I have to remember. Is the actual people that have seen the ad and at that moment they want to learn more and they click as they're interacting with the ad. The conversion is when you're not in front of the ad, but maybe you're having a conversation and you're like, you know what? I saw Central District Health had an ad about that. Let me Google that for you. And so that ad actually worked in a way that's how we want it. Change your behavior, make you remember, and it make you come back to us and find out more about our services and hopefully make your appointment.
You have a question?
Yes, I do. So is that trackable by the individual? So if this person here saw it and then you can tell sometime later that that same person came back and was converted?
Yes,
That's,
the digital campaigns, yeah, it's kind of scary.
It's kind of
Much
scary.
they know about your behavior. So they track the people that saw or interacted with the ad or your computer or your device.
yeah.
And so then later they know this person was exposed to the ad, this cell
thing.
phone or this computer, and they know that you came back because they track that. Yeah.
It's no conversions on the billboards.
Right.
Thank goodness
No,
they're
they
tracking us that far.
They use GPS tracking and live visuals.
Oh, they
and
went by
know
that
you
billboard.
saw them.
Hopefully you didn't do it while you're driving.
Unless we have a QR code, but yeah, you couldn't really scan and drive that.
Yeah. Guess if you're the passenger.
So on this slide, just going really quickly, again, for time's sake, you can see the Olympic Pulse campaign that we run in the stadium and a family and clinic services campaign that we run here on the report. Next slide, please. This was a community outreach immunization program that was targeted to Spanish speakers. So we had some new elements like the postcards or a banner in an indoor soccer field. Next slide. The health policy and promotion campaign to promote in-person health screenings and also a family and clinic services for contraceptive services. Next slide. Again, health policy and promotion campaigns. This was for imminent abuse awareness. I work with Courtney, and it ran year long, and then on a medication take back day campaign. That's one with Courtney. Next slide. And tobacco and vaping cessation campaigns. This one included a movie theater ad. And if you remember last summer with the Barbie movie or the Oppenheimer movie that brought so many people to the theater, we got really lucky that we got so many eyes on those ads. Really, really lucky. Good timing.
I like your new term, Barbie.
Oppenheimer, I put it somewhere.
Very strong.
Next slide, please. And these are some of the new brochures and handouts that we prepared. And now I'm gonna let Trent present about internal communications and our efforts and results from last year. And we're trying to do internal communications is to ensure transparent, timely, and engaging communication channels so we can empower every member of our staff to collaborate, share their knowledge, and also foster a culture of trust, collaboration, and innovation. Trent, the phone is yours.
Next slide, please, Dustin. Thank you. I'm Trent Young. I am the public information specialist here, and I coordinate the internal communication campaigns for CDH. I was fortunate to come into this environment with a commitment from Russ and leadership to present material instead of just email, which places commonly use, using SharePoint and using other tools so that people could find the information they need day to day and also be able to go back and find it again. And so instead of having to search through emails or look through your text messages or a Teams chat, we post things so that people can say, oh, where was that? Oh, I can go and find it. And so we'll do double up on communications and things as well. But this just kind of gives you an overview of a lot of what we have going on. We do have a lot going on. So next slide, please, Justin. The 411 newsletter is our main source of communication. It comes out every 2 weeks. Information is called, put out a call for content every other week. And then the information comes in either on a form where people say, you know, I've submitted this, I've curated it, my managers approved it, or we have things that we've reached out and said to the DAs or the managers like, hey, this is a certain week. Would you be interested in promoting some of your content? Or recently we've done things like with the oral health team, or, you know, some of the teams that don't get as much exposure, like our facilities team that was brand new hires, just little things like that, just to make sure people know faces and people also appreciate that we're a huge agency that does a lot. And so just to share what's going on. Here's a few numbers in there. It seems like 68% is not a great open rate for an email, but that's actually at a very high level. Some of the biggest companies in the world, like IBM, some of the biggest health systems like St. Luke's, get about 45%. Yeah. And I worked at St. Luke's. I can tell you that eyes on that level, we would have been thrilled with 65% or more. So at 69, we're sitting pretty. The 47% open rate is kind of that conversion thing again of like, well, they opened the email, did they open the link? Again, it gets ugly when you look at Constant Contact and some of those places that curate email. The average rate for agency is about 13%. So we actually have people that are engaged and want to read and want to learn. So can we do better? Yeah, that's where we're kind of talking about in this as we move forward for the future. So next slide, please, Dustin. So the highlights is kind of the future. Highlights is, it started out as an overflow. It's a SharePoint posting and it has all of the interactive content, a lot of pictures. It has longer stories because the 411 is 2 pages. So it's really hard to share content or share a link or anything like that. Highlights allows us to link to external content. We can put video in there. We can do files. People can read PDFs there without having to open another link. So it's just really handy. And it's actually going to be the future of the 411. As we slowly introduce people to this format, what's going to happen from now on is instead of getting a PDF attached to an email, which they used to get, now they get a link to a PDF. Eventually, they're just going to get a link to this, and it's going to be like online news of any kind that you're used to, where you just scroll through, and what they'll receive in the email is one of those nice little widgets that says, you know, picture and then a brief introduction. And if you want to read more, you click here and it'll take you to that portion on the page. So we're slowly moving people to that. We didn't want to just toss everything out all at once because number one, we're a big agency and we had certain things that we've done in the past. Number two, we have a lot of remote offices and people that, you know, don't come into the office or work in clinicals. And so you always have to take that, and anybody that's working in a clinical environment knows those people don't have a desk usually, or if they're at their desk, they're only there for a short time. And we also have a lot of support staff people who, if their only break to sit down is lunch, it's really not nice to expect them to read something on their lunch. So we've tried to get them where they're at by offering these opportunities for them to access information remotely. And so that really is the future. Next slide, please, Dustin. So I'll go over this one and then you can go ahead and skip to the next one too, Dustin. Our internal campaigns are really poster campaigns. What we do is we develop some fun little posters, and then we also have some little internet postings as well as emails from staff. We use this in order to be able to know, you know, things that are going on internally, as well as campaigns that they really want to make sure that people have awareness about in the clinic or other areas. One last slide, please, Dustin. Thing that I'd really like to share as well here is, and I kind of mentioned it, SharePoint is the intranet. I tend to forget that a lot of people aren't familiar with the term SharePoint, but it's our new intranet Microsoft platform. We switched over right after I started in about late June. Since then, as you can see, we have 166. Well, this was just for 2023, 166 staff profiles, which is what we mean by that is that Russ had made a commitment to making everybody's profile visible from the front page. So we have a little directory that drops down and everyone has a page that has their picture, their name, and their bio on it. That's huge. I've worked for a lot of places. Not many places have anything more than that. In addition to that, there's 55 site pages that have a dedicated page for each committee, each division, each subdivision and program. Anybody that is interested can find information related to those topics, and it's growing as we move over from our intranet. Just really wanted to highlight one quick thing. We post our Ask the Director, which is where people come in for questions for Russ. It averages the 60% open rate. As we mentioned before, the open rate is 60% is really well. But what Russ doesn't know, and I thought I'd surprise him with this, is that the Ask the Director page on the intranet is the highest viewed page that we have by far. It averages 100 views every time he sends out an Ask the Director, which for calendar year 2023 went up to 3,000 views, which, just to put that into perspective, our policy page that everyone has to use to click from any policy has 2,700 views. The staff directory that I just talked to you about, which is so great, has 2,400 views. So you can see people care what Russ has to say, and people are engaged.
Yeah, but
No pressure, Russ. And then, not to make the IT team upset, but are they where people go to enter IT tickets has 1,000. So just wanted to share some of these things for you for internal communications. And as I kind of talked about, we want to just migrate people more and more as the comfort level increases to get them away from conventional email and things like that and into this environment where information can be stored and accessed, and we have a constant, one-on-one relationship with them. We've also opened on some of our postings for people to be able to add comments there. So they can they can add a comment, they can do whatever with our internal news feed.
Intranet, is that anonymous?
It is not anonymous, but we have other avenues for them to do anonymous content.
Do you get many comments?
We mostly just get likes. People are shy. So yeah, I've had people say that, but we've had a growing movement of, especially with the staff profiles. There's people that will like and welcome the new employees. So I think that's the avenue where people are going to start. But one of the things that we're hoping is that for every time we have a large initiative, or information that goes out like a health alert network warning, like we have with measles, or something about staffing. In addition to posting an email, we'll post it on the intranet. So again, people have that where they can say, well, I can't remember when that came out. Let me go check and go up and do the search bar and look for measles. There's the health alert. So, there was a staffing change that this is when that happened.
So Trey, let me ask you this. The comment made here, I think it was Dr. Cole, about 7 out of 10 pills now are laced with fentanyl. How do we get that information out to the general public?
And, I think it's my, familiarity is with internal communications, but I always think that you have to build your mission, and that starts with it. So everyone here has to know this, and then you have to have that group of people that are ready to take that out, so that every person in this agency, it's like we're building the content for National Public Health Week. And part of it is that no matter what agency you work in, you're all public health. And so those should be the tools that all those teams are armed with, or to go out and say, yes, I'm here to do oral health at a middle school or an elementary school. But if you have questions about that, here's the contact, here's the materials, here's, and not to sidetrack anything, but we did just send out a news release yesterday related to the materials that are available online that people can order for free. And so I think we sent that internally for staff as well. And so if any one of our staff goes out and has a question related to, like, I have pills at home and I'm worried my kids might get into it, they can say, well, you can order a medication lockbox for free online and they'll send it to your house. You don't even have to leave your house. They'll just, and that way you can do what Courtney said, you can at least start protecting yourself and
And I
educating.
appreciate that. I think there's a large part of society that live in their phone
Yeah.
or their computer. There's also a part that has no idea how to even turn the damn thing on.
Yeah.
And I think that's missing that, or they're maybe too young and they don't have the phone yet.
Yeah.
And I think we need to maybe spend more energy on the super seniors and the very young.
Yeah.
Especially with something like that, a statement like that would scare the heck out of a lot of people.
And I actually think that's
Sure.
So from a marketing point of view, reaching out hard to reach target audiences, there are different strategies. We do have an incredible outreach team, and that's just being there, having those conversations, going to events, going to senior centers. So we have that element. The marketing department doesn't manage that, but if they have materials to print or to develop, we help them with that. So that's one element. And then each time we have a marketing campaign, we ask those questions like, who are we trying to reach? Where do they live? And how do they get their information? And so billboards are really good for like people that don't have access to internet. For example, the example I mentioned, like a postcard that you get at home, a billboard on a soccer field. And we wanted to reach Spanish language speakers,
Sure.
know that they like soccer and they're playing. So there are different strategies depending on the audience that we have those conversations before we start the campaign.
So, and I'm not a marketing guy, so tell me if I'm way off here, but if you had a billboard, not a billboard, but a big, I don't know what you want to call it, sign that you could put up at the front door of a school that say 7 out of 10 pills are laced with fentanyl, wouldn't that be good for us?
So marketing to minors is muddy waters, if you will. So the best approach is to work with the schools.
Sure.
And again,
And you have all that.
for share those materials, we can print them for them, share them with them, educate their nurses and their faculty, do presentations. But for example, we cannot do social media, we cannot target minors. But at the same time, we have the vaping and tobacco cessation ads in the movie theater where people were watching Barbie. And we knew that a lot of youth were watching those ads. That was the target audience. That's why we put it there. It was summer and the theaters. So there are ways that we can reach out, but there are ways that we can't. In all the digital and the social media, we cannot target minors.
Why can you not on social media? Is that a policy of this board?
No, it's a policy of social media.
Oh, okay.
Is that 12 and under or 18 and under?
It's 18 and under.
But we're missing about their,
Real quick, because I mean, I remember as a kid in elementary school and seeing having someone come in and teach and showing the black lungs and whatnot, and just how impactful that was at such a young age. But in terms of that marketing outreach, I mean, do we have people going into the schools to do those lectures on a regular basis about the opioid problem?
I think we all know that the kids are in social media regardless. So if I put an ad and I'm targeting 18 to 20, I know a 16-year-old is sure seeing it, but I cannot specifically target minors. That doesn't mean they're not being exposed, and we have that in mind as well. And then the other thing that we do is we get reports of the data that I show you, so we can see if the ads are working or not. Are people seeing it and are they interacting with the ads? And that will inform our next campaign if we were using the right platform and the right strategy or not.
I know we're seeing a lot now about measles. I think that's coming from the health districts, a lot of that, which is great. I think it's great, but something like that similar would be awesome.
Coming to that, there's a combination, and this is why marketing and communications are together. There is a overlap with organic content, which I'm not paying to have out there, and we will work with local reporters to educate the community. I cannot control if they want to talk about it.
Sure.
And then paid marketing campaign, I control the message and where it's showing.
Well, it sounds to me like you're getting it out the best you can. Zach, you want to add anything to this? You've been reading.
I got one more for Trent.
Sure.
So that platform it's a Microsoft platform?
Yeah.
Is it a subscription service that we're paying monthly for, or is it part of a bigger package of Microsoft licensing?
So yes, it is part of the Microsoft package that we pay for. There's different levels, but yeah, when we moved over, we all have a certain level of access. I can't remember exactly what the level is called.
So it's part of our Office 365 licenses that we use for all of our staff. We transitioned to Office 365, I think, just shortly before Trent started, about 6 months before. It was just an upgrade from our existing platform, SharePoint, and the other workflows and forms that we use is all included in that.
Okay, Zach, you're up.
Dustin, next slide. Oh, yep, there we go. So my name's Zach. I'm the brand strategist here at Central District Health, and my job consists of 3 main areas. One is reviewing external materials for branding standards. One is managing content on the external website, and then one is managing our social media. So we'll start with branding. We review and create materials created by all of our programs to ensure brand consistency. When people see our logo, they know what programs and services we offer. When they see our colors, they know what programs and services we offer. They know who we are. That's the kind of thing, the repertoire we want to build in the community so that people know to come to us for those things. And so these numbers here are help desk tickets that people submitted. So that's things like brochures, flyers, posters that people designed and asked me to review for branding standards. 19 of those were social media posts, 18 were flyers, 2 of them were flags and other pieces of swag like tents, 13 were website content changes, and 5 were reviews for branding. So that's just 1/3 of the job that I do. Dustin, next slide, please. And one main part of that is managing our website. So this past year, we completely overhauled the design of the website and consolidated a lot of that information that was there. The old website was a mess, right? You had to click through like 6 links to find any given piece of information. And so we reviewed as a communication team every single page and consolidated those so that people didn't have to go searching so far for that information. And some of what that included was 113 total web pages consisting of 153 posts. And within that, there were 467 PDFs that we had to upload, 8 forms, and then 200 redirects that had to be done. So the new website looks much better. It is much easier to navigate. And it was a really big lift that we spent a lot of time on this last year to make sure that people are able to access information in a timely and accessible manner. Dustin, next slide, please. And then last thing that I do is manage our social media platforms. So we're currently on 6 with 8.9 thousand followers between those platforms. Last year, we made 495 posts, reaching a total of about 120,000 people, including 14 advertisements. So Dustin, next slide, please. We'll kind of go over what that looks like platform by platform. So on Facebook this last year, that's where we get most of our followers. That's where we get most of our engagement. We reached about 186,000 people, which was down 15%, but that sounds a little scarier than it actually is. So the reach breakdown on the right-hand side over here shows that our organic posts, which is something Maria mentioned a couple of minutes ago, those are posts that we don't pay for. Someone in-house designs them, and then we just put it on Facebook or Instagram for people to look at. Engagement with those posts was up 100%. So what that means is that we're getting more content from programs and services within the building. And they don't have necessarily money that they want to spend on these things, but they have messages that need to be shared. And we're getting a lot more engagement on those posts over the last year. And as well as content interactions. So that's when people actually comment or like, one of our posts, was about 1.4 thousand this last year. So Dustin, next slide, please. So this is what our audience looks like on Facebook. I won't spend a ton of time going over the audience on each platform, but if you have more questions about that, please reach out to me and I can go over some of those numbers more in depth. But on Facebook specifically, we typically reach middle-aged women. So the 35 to 44 age group is really big on our Facebook page, primarily English speakers as well. Next slide, please. And then Instagram is our next biggest platform. We had 142 posts go out on that platform last year, reaching 59,000 people, which was an increase of 588% from the previous year. So we got a lot more content that was able to go on Instagram, and we got a lot more people to engage with and interact with that. Next slide. And then our Instagram audience is kind of similar to Facebook. I won't go over a ton of these in detail, but we get a lot younger audiences on Instagram. Instagram's a much more popular platform among like the 20s somethings. So that's where we try to focus some of those efforts as far as organic posting is getting things relevant to that age group on the Instagram. Next slide, please. And then this is just some more in-depth details of what reach and profile visits look like for Instagram. So the number I want to highlight here is specifically the profile visits, which were up 36%. This is really good because it means that people aren't just seeing our posts on Instagram, they're actually visiting our page to learn more about the programs and services that we're offering. So this was a really good trend that we saw within the last year, and we hope to keep seeing increase. Next slide, please. Twitter underwent some new management changes this last year, which led to some analytics getting lost within ownership changes. But we still garnered about 4.2 thousand followers on the platform, and we tweeted about 107 times this past year. Twitter is not as big a platform as the other two, just primarily because of the character count that you were limited to. So we can't put as much information in those posts, but we still make sure to get our messages out on that platform.
Question on that?
Yeah.
Why did it peak in November?
I don't have data specifically for what that spike is, but I can do some research and get back to you on that.
Interested to find out what everybody was interested in.
Yeah, I don't have that data at this moment, but I can find out and get that.
In your script.
Yeah. Next slide, please. So we're also on LinkedIn. Now, we don't post nearly as much on LinkedIn, but within the end of last year, we started getting more expert columns in the Idaho Capital Sun from people in various programs. And so we get those on LinkedIn so that people can see what experts here at Central District Health are talking about in their respective fields. And so we got about 415 followers on LinkedIn this last year. Next slide, please. We also have a YouTube account that is primarily used for these meetings, as well as videos that are designed by Peppershock, our third-party marketing company. And so they have designed a few videos for various campaigns. The ones mentioned here are Flip the Script and Telehealth. And so those videos can be viewed on our YouTube. Next slide, please. And then new as of December 2023, we created a Nextdoor page. The advantage of Nextdoor as opposed to a lot of the other platforms is that we can more specifically target the service area that Central District Health covers. So, right, with Facebook, theoretically, anybody can just look up Central District Health, regardless of whether or not they live in our service area, and see what we have to talk about. Nextdoor means that we can specifically target our service area, and only people who would find use in our services will see those posts. And even more in depth, you can target to specific neighborhoods. So if, for example, if one program is holding an event at an elementary school at somewhere in Boise, we can post posters to that neighborhood specifically so that people living there know that there's something happening half a mile down the road from them. And so we foresee this being a really big platform going forward for us because it gives us a better way to interact with our service area as opposed to just having the messages available on other platforms. We can specifically talk to people in those service areas.
So that works. That you just have a list of everybody's IP address that signs up for, or do they sign up? How does that?
So Nextdoor, yeah. So Nextdoor has a public agencies function. I guess I should start. Nextdoor itself, when you sign up for it just as an individual, requires you to put in your address, and then they send you a letter in the mail to verify that you are the owner of that address. So when we sign up for our public agencies page, it collects all of the people who have signed up for Nextdoor that live in those areas. And when I tell them that we cover Boise, Elmore, Ada, and Valley counties, they say, here's all the people that live in these neighborhoods. in those service areas that you can.
So they basically put all that list together.
So they opt in when they sign up for the
It's
platform.
really helpful. Our neighborhood has a next door, you know exactly what's going on in the whole 1,000 region. Really interesting. It's a really, again, it's a local service.
I've never heard of it before. I'll have to check it out.
It's something we're looking forward to getting some more data on, just because some like initial posts that we've made get significantly more reach and interactions than they do on our other platforms. So I think that Nextdoor providing that option to filter by relevancy to where people live is going to be a really useful tool going forward.
Well, I saw a lot of interest back here from District 3.
Yeah.
Chair, can I ask?
Oh, sure. Yeah, sorry.
Yeah, I'm really curious. I mean, looking at the trends on all the socials, it appears that we Idahowans are grizzly bears hibernating. Because if you look at the engagement, I mean, fall and winter, it's like we're all asleep. And I noticed that most of the engagement is when we're out, foraging again. So I'm just curious if you have what accounts for the interest in the seasonal.
Yeah. So the main reason that we get stuff in the summer is people in programs within Central District Health will go to more events, and those events typically they'll spend some advertising dollars on, and advertisements inherently get significantly more traction on those platforms. So that's why there's mostly spikes in those summer months. Is people are outside.
Zach, does it cost the health district to join this? Is there a fee to this?
Nextdoor? Yeah.
Wow.
Nice.
It'd be great for accounting too. So
Yeah, that's what I'm tripping in my little brain.
We can spend advertising dollars on Nextdoor, similar to how we would Facebook or Instagram, but we did not have to pay to sign up.
Well, that was kind of my next question is, do we need to look at maybe throwing some money in that in a budget so that you can?
So as of right now, the programs, with whatever grants they receive, we'll put forth some of those funds towards advertising, and we'll spend that on things like Facebook and Instagram specifically. But hopefully this next year we'll get a lot more traction with those programs saying we specifically want to put this in this neighborhood and advertise to them. So
So that'll come into Laurel in a budget.
yeah, so it would be part of the existing budget that they would already have,
Okay.
whatever grant dollars that they receive.
That program level.
Yeah.
Little, right? Good. Any questions? Go ahead.
ya noté que no hay muchas personas en la comunidad hispana que there's not a lot of Spanish people that are engaged or Spanish speaking.
In social media,
Yeah.
correct. And that's something that we're also gonna explore with Nextdoor, because we believe that they might be having conversation in Spanish. It's really new and we're just experimenting and learning. But we know that they have the means to access that information.
Yeah.
Yeah, here it's at 52.
So being one of the new ones here, how are the marketing campaigns developed? I know the naloxone or promotion might be one. In the past, the COVID shots. How are these and what are the ones that are planned? If this is a recap for what we did last year, what's on tap or what are the themes for coming up?
I can speak to some of this a little bit. So typically what we'll do is we'll sit down with the program manager or whoever wants to develop their campaign. We'll see specifically what things they want to talk about, who they want to target, and how much money they have to spend on advertising. And if it's not a lot of money, we'll typically recommend that they put ads on Facebook or Instagram. So if they have more money than that, we'll refer them to Pepper Shock to develop a little bit more in-depth materials. So that's something that Maria would talk about a little bit more, but depending on the amount of money, typically I will handle some of that and we'll develop materials together. But with enough money, Pepper Shock to do all of that.
So then, like, for instance, the COVID-19 shot has largely become passé. And I would be concerned if we're spending any resources promoting that any longer at this point. I brought something up, pointed it out to Commissioner Rogers last time, that Central District Health was doing things like wrapping ice boxes at truck stops.
Health
Or health welfare. Yes. So, or wrapping buses and things like that. How do we know? You talked about the clicks and the engagement online. How do we measure the effectiveness of, let's say, a billboard? We joked a little bit about it, or the effectiveness of wrapping an ice machine or a city bus. How do we gauge return on investment?
Yes, go ahead.
So social media marketing is not like a hard science, but we do have goals and ways to measure what we consider success, and it will vary depending on the campaign. So for a billboard, the vendors that contract with us, they know the traffic. And so that's the number we have. We know how many people drove by and potentially saw those ads. Another way is to have a special link that we can track if people use that link and we know that was only in a billboard or in a postcard. We know they came from there. So it's another way. And then the last way is we have a customer survey and we ask people how you heard about that. So that's another way that we can kind of gauge or if they heard on radio or they heard on social media. Not hard science, but that's how we track their success. And then for certain programs, ultimately, more people doing telehealth appointments, for example. And did that coincide with when we were advertising it? Correlation and causation, but we can track that. When people were calling after the campaign, I think the campaign can get some credit on that, right? So there are different ways. Most of them are recorded there, and we always track those numbers just to make sure that it makes sense to continue doing that strategy or that platform.
Here, so having 6 kids and know how much they use socials and whatnot, I'm curious in terms of like our reach and the number of followers, is engaging influencers. I mean, are we allowed to do that to say, hey, look, we have an important message, say we do the opioid message, not just reaching our small group that do currently engage, but extending that reach through Instagram or especially to that generation that we want to get the message out to. Is there a way, I know there are a lot of influencers that have hundreds of thousands of followers and whatnot. I'm just wondering if that's something you can consider in terms of increasing engagement.
Yeah, I can't speak to like specific influencers or anything, but one of the ways that we try to interact with people who don't currently engage with our materials is, so Facebook, for example, lets you set specific interests that people have, like a more specific radius for where they might live, for those things. So like one of the things Courtney mentioned was where do people go for like these naloxone drop boxes. So we would be able to target those areas and say, these people look at XYZ things on Facebook or on other platforms on social media and say, even if they don't follow us, because we're spending money on these advertisements, Facebook will have that stuff show up in their feed. And so that's how we garner those new followers and those new engagements.
Yeah, and what I'm talking about is say, you have the young person doing the makeup campaign, but then they, you pay them X per ad to get the word out, but and by the way, I found out from this that there's this number of people engaging in this dangerous activity, et cetera. And then they're 250,000, here it's going to be tens of thousands or 50s of thousands, but still that just throwing out an idea that might be helpful in terms of just watching the patterns of, my younger generation in my household and how they engage. And then all of a sudden they're coming to you. So it's just throwing out interesting construct because it might be very cheap to get us a broad reach, especially in those age groups where we do want to impact our health. Yeah. Thank you.
Well, and I think it's really hard to know how many young lives maybe we've saved already. That just happen to see an ad somewhere on their phone, on their computer, and you never get that kind of data. But all you need to do is save one and it was worth it. Okay, anything else for Zach?
Thank you.
Thank you. Thank you. Okay, we're gonna move on down the agenda. The next one is review and discuss the FY24 financial report. Welcome. I will turn it over to you.
Thank you. Already got it out. I'm still grappling with the fact that Zach said middle-aged woman, we're 35 to. No, look. So, guess I'm in the mature.
Yeah, what are we now?
promote the.
Yeah.
The best deal.
So, we've had some great presentations today. I think following this up with budget is a little bit difficult to do, but we'll keep it as we can. So the report that we've got on the screen is 67% of the way through the fiscal year. As I've been doing the last few months, do a brief Luma update to start. They have officially assigned us our liaison, and health districts have had one meeting already with the liaison, and they are prioritizing the issues that we've been struggling with. Top of the list is reporting. We are feeling a lot more confidence in the integrity of our numbers, but a lot of that still has to do with Conan doing a lot of manual reporting, pulling the information down into reports that he's using to roll up into the report that you see before you. So that is primary focus. The other issues that they're continuing to focus on, like P-card transactions and some issues with that. Slowed business down has been a disruption, but not as much as of a stoppage as the reporting function has been. So appreciative to them for prioritizing those issues.
Or are you getting it, but it's just late?
We're getting the information, but it's not coming to us in the format that is the most useful. So like Conan's having to pull lists of transactions and calculate that into what categories it falls into, rather than being able to pull a report that just shows us where things would go at the level of detail that we're able to see before. So the information, the data that we're getting out of it is available, looks different, and there's still some issues with how it's categorized going in to the reports that he gets. So if you miss a category in Luma that wasn't there before, when a transaction is going into the system, it doesn't end up in the right category for reporting. So those things.
Is this stuff that the auditor's gonna pick on us?
Well, I don't know yet. So far, we haven't had any issues with our audits, but those are all pre-Luma. I think that any state agency or any agency using Luma is going to be in the same boat with us. And I think we still have our controls in place. I believe that our financial integrity is intact, that it's not going to cause any audit issues. And if any questions do come up, we'll be able to explain the why behind it. So we're not in a position where we're concerned about upcoming audits. But certainly we'll be aware and cognizant if anything does come up that's related to Luma, what explanations will be.
But you feel like it's getting better, just gonna take more.
Yeah, it is getting better. Some of that's just our getting used to the system. We expected there to be a long transition. And then also I'll say just Conan's facility with being able to get what he needs out of the system and work with it in different ways and build his own reports. That's great.
Great.
Hey, so our revenue is coming in at 62% when you look at just that top bar across without the county contributions and interest revenue. So a little bit behind where we plan to be at this point of the fiscal year. When you include the county contributions and interest revenue, we're coming in at 74% of where we plan to be this far in the year, which is of course above the 67% that we'd expect to be at this point in the year. Looking a little bit more into the details, our total fees that we've received so far are coming in right on budget. Community environmental health is slightly above budget, and family and clinic services is below budgeted amount. We've been seeing that over the last couple of months. Still working on increasing the fees that we're receiving in FCS. For contracts, we have contract funding showing in administration and support services that we didn't plan for at the beginning of the year. That was the infrastructure grant funding that we received. So we've seen that on the last several reports. And then both community environmental health and family and clinic services are slightly behind planned amounts for contracts received. Our other category, this again, as a reminder, is a category that includes our non-federal grants. So grants that we receive directly, and we are far above where we plan to be at this point in the year. A lot of that has to do with the receipt of opioid funds more than we planned, and we just got more notifications in the past 2 weeks that there are even more opioid funds coming in, so we may see that depending on how fast it goes through the Attorney General's office and we actually receive the funds. That may be in next month's report, where that amount will be even higher than what you see up there right now. Moving on to expenditures, we're seeing the same trends that we've seen so far this fiscal year. I know the numbers up there are really, really tiny on the screen. Hopefully you can see the report that you have in front of you. Personnel is at 60% of planned budget. Operating is coming in under at 62% of budget. Our capital is at 70% of budget. That has gone up significantly since last month when we had only spent about 6,000 in capital. And that's because we had a HVAC repair project and some IT costs that are showing up there. So we're close to planned amount there. And then overall for expenditures, we're at 61% of our planned amount at 67% of the way through the fiscal year. Don't think I'm controlling my promise of completeness as interesting as the last presentation. So moving on to page 2. This, as usual, shows our comparison over the past 2 fiscal years. Fees are slightly behind where they were the past 2 years in both community environmental health and family and clinic services, but pretty well on track where we expect to be, not significantly different. Our food programs are slightly below last fiscal year. We may continue to get some of those payments in, but again, pretty close, and they're well above where we were 2 years ago. For the clinic, our immunization fee revenue is down compared to the last couple years. Reproductive health is close to last year, down from 2 years ago. Child dental clinic is about the same. And then our home visitation revenue is up from last year and about the same as we were for FY22. So just seeing some ups and downs in the clinic when you compare it year over year. Our contracts are comparable to where we were in FY22 and are now showing a decrease from FY23 to FY24 when you compare those 2 years specifically. And some of that's because we received one of those first big bumps of opioid funding in February of last year. So we saw that big jump in contracts received in FY20 or FY23. Okay, operating costs are under by about 6%, personnel under budget by about 8%, when you look at it this way. Our trustee and benefits is over our budgeted amount by 16%. Reminder on that one, it doesn't always come out evenly. It depends on who we're contracting with, tends to be more front-loaded at the beginning of the fiscal year than through the middle and the end. So not out of what we'd expect. And then our capital outlay costs, as we talked about on the last page, slightly over where we plan to be with that HVAC purchase that we made last month. Or repair purchase, I should say. And then finally, moving on to page 3. Okay, so this is our cash balance statement. Our overall cash balance has gone up as we anticipated from last month. We're now just over 10 million. But same as we've seen before, most of that's allocated to either restricted or designated funds. We'll talk more about that as we progress through the page. There are no new updates for our special projects and carryover designation. You know, the employee retention was paid out. The EH system demo calls have continued. When we met last month, we just had one scheduled. We hadn't had any of the calls yet. That first demo call has been completed and we have 2 or 3 more scheduled. We're hoping to be able to make a decision on which EH system to go with by the end of this fiscal year. So the meetings that we have up until then will charge to this funding stream for those demo calls, but we may or may not have any big payments come out of that money that's designated for the EH system during this fiscal year. Depends on the implementation timeframe of what we end up going with. And so far what we've heard, there are a huge variety of implementation timeframes, anywhere from 2 months to up to 6 months. So I'm hoping for one with a shorter implementation timeline, but it'll be with what fits the needs best of the environmental health inspectors. As we talked about last month, our van purchase is still showing that balance of 100,000. And decisions to be made on what we want to do with that. That brings us to a total of 367,000 in our special projects, and not much that we've spent so far other than the employee retention incentive. Our personnel reserve for the 27th pay period that we talked about earlier today is right where we need it to be, 290,000, and we'll potentially allocate more to that at carryover time this year to bring us up to wherever we need to be in the how many 11ths we are, getting closer to that extra pay period year. Our operational reserve remains unchanged, 4.4 million. That's our 3-month cash flow target. And our capital reserve fund also remains unchanged. And with our restricted funds and that total of the reserve fund designations, that leaves an undesignated, unrestricted balance of just under 400,000. Remember the last couple months that amount was showing as negative, and I assured you that by this month it would not be when we got that Ada County payment in. So this is exactly where we expected to be with our cash balance statement. That concludes my presentation.
Question on the very bottom, that
Yeah.
Luma issue with boys not getting paid, that only came to $1,450.
That's, so what we did on that is just having extra cash on hand in case anybody doesn't receive their full paycheck. I don't anticipate now that that's happening more smoothly, that we'll need to dip into that. So previously we had under $1,000 of cash on hand, put a little extra to that. What we saw happen 3 or 4 times closer to the rollout of Luma was that people received half a paycheck, didn't receive a paycheck, and they really needed something to get them, and just 1 or 2 people each time. It wasn't like a whole group of staff. So they needed something to get them through to that next pay period. In every case that happened, Luma did in the middle of a pay period paycheck, so they made it right by the next Friday. So we just needed enough on hand to basically get 2 or 3 people through to that in-between pay period if it comes down to that. We do need to do that. We have an agreement that they would sign that as soon as they receive that paycheck, they pay us back right away. Or if need be, we could withdraw from their paycheck if they didn't. So they have to sign an agreement to receive that cash from us.
Well, I guess what I'm saying is wasn't as big as a problem as we thought it was gonna be.
No.
Only 1 or 2 people.
No, and the last time that it happened, it was that somebody changed their bank account for direct deposit too soon. So it wasn't even a Luma system issue. It was timing on behalf of the employee.
Hey, any questions from Laurel? Yeah.
Laurel, question on the clinical services being behind. Was that affected by the Change Health Act that happened nationally? So about half of medical payers or medical systems and offices were affected by a large hack 6-8 weeks ago, maybe a little longer. But when that happened, payments halted for about half of the nation's physicians. Supposedly that's fixed and they're catching up on the lag. But what else is happening now? Because I do some national calls with physicians every week. Money's going missing from some of the accounts. So in terms of an audit trail, I'm just wondering if the EMR payment system for the CDH is affected by that national hack that happened.
We have not heard anything about us being impacted by that. So MedMan is still handling our billing, and we haven't received notification that they've been impacted or that our Athena system's been impacted. We have been seeing a lag in the receipt of those funds through this fiscal year. Our clinic is busier than we have been before, but our fees are still lagging behind. Some of that, Stephanie's worked really hard with MedMan to fix some of what we saw as not following our billing policy the way that they were supposed to. So she's worked through some of those issues with them. We've started to see it pick back up. We are busier than we've been, so that's encouraging to us, but the fees haven't started to roll in as we expected. So there could be some external factors that I'm just not aware of impacting
I
it.
just wanted to put that on the radar in case they wanted to.
Yeah, we'll look into it.
Thank you.
Well, I think the other outstanding thing is that interest income, that 341,000, that is something that's kind of like gravy. So when we get down the van discussion, I think that makes that decision a lot easier. I mean, any more questions for Laurel? All right, now we're gonna go down to an action item. This is to discuss and vote on the budget guidance for the FY 25 budget, including compensation for the CDH. You have something in here, because I don't have anything.
No.
Okay.
Okay, so for some of the newer board members, I'll just kind of quickly review the steps of budget development, budget approval for fiscal year 2025, which starts on July 1. So we're on the state fiscal year cycle, not the county fiscal year cycle. So essentially today I'll ask for, as an action item, guidance from the board on what I am proposing for our request from the counties, which is the part that you directly control as far as your decision making, and then included in that would be salary increases for our staff based on performance reviews. So just for some perspective on that, one of the challenges we've had, you all are aware of that, is wild inflation over the last couple of years. It hasn't really completely settled into the 2 to 3%. It's still above 3%, which impacts our entire budget, and certainly trying to keep pace with increasing salaries that are happening throughout our communities. They're the organizations that we compete with. One of the things we do is we do an analysis. We reach out to all of our counties and look at what the counties pay their employees, which generally happens at the start of the fiscal year in October. So it's fairly recent information, and we've tracked that for a very long time. And then we also look at what the state is doing for their employees, because unlike other health districts, we're very much competing with state agencies. This is where all of their headquarter offices are located, including the Department of Health and Welfare and the Department of Environmental Quality, which has similar employees, similar job classifications as what we have. So timing, and then I'll get into the specifics, is today I'll ask for guidance, and then Conan, Laurel, and I, of course, the other division administrators and program managers, will work on developing a budget that I'll present to you for approval on Friday, April 19th. And then after that approval, what we'll do is we'll take the information out to each of the counties. And you all, if you're not a county commissioner, you will be invited to be there to represent the county who has appointed you. And I know many of you often join me for those budget presentations, which I really appreciate. With that, we'll talk about what we've done for each county. So we put together, Maria and her team has worked with all of our program managers just to show what the data is, how much, in terms of number of WIC clients, how much WIC vouchers have been spent specifically in your counties, and a whole host of other data points. So I'm excited to be able to share that. It's a new format that we're going with this year, a little bit more, for sure, more content. And then on May 10th, the board's basically out of it then, as far as the budget decision making. That will go to the chairs of each of our county board of commissioners. We're going to meet in Valley County this year. We rotate that chair position among our counties. Last year it was in Elmore County, this year Valley County, and we'll talk about where you want to host that. We have two options. Donna did some research and has some data for us, and we'll do that under the director's report. So on May 10th, it'll be up to the chairs of each of our boards of county commissioners to vote on it, and simple majority vote. So 3 out of 4. And once that decision is made, if it's affirmative, then that's what we have going into July 1. And if it's not supported, there would be the options if they wanted to provide an alternative at that meeting, or it's possible that we'd have to have a subsequent budget meeting. As long as it's done before July 1, we'll be fine. So that's the process. What I have asked for from the board, most years, the exceptions were I call them the recession years that started in 2008, where we requested 0% increase from our counties for 2 years in a row, and then a 2% increase, and then back on track to what we've done historically was asked for a 3% increase from our county. So what that covers is about 70% of that's personnel, and then the balance of that be primarily operating costs for the organization. So that's my first ask, is to have the board authorize us to develop a budget based on 3% county contribution increase. So I mentioned 70% personnel. About 35% of our budget is now funded by our counties. And that was part of that House Bill 316 shift away from the state providing contributions to that being the responsibility of the counties. So 30% increase from our counties. And then really the base for salary increases, and this will be determined by, as we develop the budget with that county contribution and other anticipated revenues, is a 3% for our achieves performers. And then essentially there's 3 steps: does not achieve, achieves, or high performer. So 3% for achieves and 5% for our high performer staff. I would like to have some flexibility to do more than that, because as you will see in the county sheets that I mentioned, as far as the historical salaries as well as health and welfare, we are getting a little bit behind based on what we've been doing for our staff compared to what they've done for their staff over the last 5 years. So the request is build a budget on a 3% increase from our counties and include in that a minimum of a 3% for our achieves performers and a 5% for our high performers.
And that 3% for the counties comes to about $160,542 as divided by the 4 counties. So it's not a lot of money. I'm not saying one way or the other. I'm just giving you that rough figure that we're looking at on the county level. One of the issues that we do know we're going to get hit here is our medical insurance is probably looking at another 9% increase. And that's a big hit for a lot of counties to cover that insurance. But you also have to look at their valuation and how much new construction you have. Not a lot of things go into that decision. But everything's going up, but wages. How does the board feel about that? Do we want to go with another 3%? Do you want? I think one of the things that really helps is the meeting in May, as Russ indicated, is the fact that and we're growing. We're having a lot more folks coming into the operations. I mean, Oral's just stated that they're busy. You have to look at those numbers, and that hard concrete numbers is really what helps the rest of those county commissioners say, you know what, they're doing a lot more in my county, so they'll support that. That's important that you bring that data with you. And as everybody knows, fuel's not going down, insurance is not going down. So those are things you have to consider and look at. My feeling is that for employee morale, everybody, I think, needs a little boost every year. Just for employee, otherwise people feel like they're stuck. Comments? Is this an action item?
A question for Russ on the 3 to 5% for the scale. Would the low end of that still get a cost of living?
So that achieves, if you're not performing your job,
You're not performing.
no pay increase.
0, no cost of living, anything.
And if you're achieves performing, which is really the base level, not going above and beyond, they would receive a 3% proposal. That's a little less than where inflation is trending right now.
Okay, moved on first.
Well, again, being new to the process somewhat, is there a point at which we take a step back and look at maybe certain programs or certain things that might be hitting their obsolescence? Or is there just an assumed perception that everything that's being done within the walls of the four counties is 100% appropriate, and that we then just add 3% on, or can we reshuffle the chairs on the deck and find a savings somewhere to help offset? That was one of the things
Talk a little bit about that.
legislature is a lot of the divisions, they just kind of pile on, and you say, well, wait a second, do we really need this thing that's been here hovering for the last 15 years that might not be serving very well?
Yeah, so with the county funding being about 35%, it supplements programs that we have that don't completely pay for themselves. The grant funding that we get in comes mostly from health and welfare from the state or other partners. Some of that comes from direct grants, or like the opioid funding comes directly to us. So typically what we're doing with the activities that we have when we receive those funds is building our activities to meet the deliverables of those grants. Most of them come with an end date, so it's very clear when they meet their obsolescence. They're not just funding streams that continue in perpetuity. Some of our funding streams are intended to continue indefinitely, like those that fund the health inspectors, things like that. They're not program specific, but any of the programs that are related to outreach, grants that we're doing in our community, things like that, most of those have a very specific period of performance. So what we're doing is those reach their end. Sometimes the activities are updated. We have new deliverables to meet. And every single time we're getting those funds in, we have a contract that gets reviewed, a whole review process by everyone internally. So we know if deliverables have changed, we know what activities have become obsolete. And then for new funding streams we're applying for, we've talked a lot about Bill, our grant writer. Before we even apply for funds, we have a vetting process that we do internally to make sure that anyone who's going to be actively working on that funding stream approves of the activities and the deliverables within that. So I would say we are always very cognizant of potential obsolescence when funding streams end, when deliverables change. When we have program audits, we're always meeting the funding goals, payment goals, and the deliverables within the funding streams that we do receive. So it's not as if we're just sitting on the same funding and not aware of whether or not the activities that go along with it are things that we should or should not be doing.
Well, and if you look at it, it's a $17 million budget. The counties are throwing in, what is it, 5,200,000, 300,000. So it's really about 30% of that, our total budget. But I understand what you're saying is the fact that do we ever not do raise? Do we ever go backwards? Yeah. Years ago, and the way it works in the county is you lose valuation. Your house values go down, everything goes down really fast. So you have less valuation. You either have to tax twice as much to keep that budget, or you got to start cutting services. And that's no fun. But we would come back, I'm assuming, as a board and say, we're going to have to cut some of these programs because we just don't have the funds to do that. But years ago in the 80s, the school districts went through a big shift, and we had to RIF 2 tenured teachers from our school, Cascade, because we just didn't get the funds from the state. And there's a whole process set up that you have to kind of look at what's the most important. And I think you really get back to the roots of what you originally designed. If opioid funds go away tomorrow, we don't get that money, that program is over. That's kind of how a lot of these grants work, even on a county level. And being able to adjust fast is important there.
Well, that's good. And we have the strategic plan so that we can look at it, the goals and what we're meeting in terms of the community health that matches up to what you're saying. So we have a say in that end of it too.
Well, and years ago, we did away with like the Meals on Wheels and some of our adult immunization issues. So we can try to keep on top of that.
Well, and even looking at Laurel's budget here, when you look at the land, the second page, sewage disposal, that's way down this year versus the last few years. Well, we're not getting subdivisions, we're not getting individual septic systems that are coming in for a permit. However, I think in our county, that's going to change because we've just approved 2 or maybe 300 lot subdivisions. And some of that's going to be on city sewer and water, some of it's going to be individual wells. So that figure is going to come back up. I think probably before the end of fiscal year, but we shall see. Any more questions? This is an action item. We agree with the 3% ask from the counties. Need a motion in a second.
So moved.
Okay, we got a motion and a second to concur with the 3% increase to the county assessment for FY25 budget. All in favor, please say aye.
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 Those opposed? Motion carries. Anything else you need? You want a motion on the 3% and 5% for the employees, or that's just part of normal business?
I think that'd be fine. Just the 3%'s the main thing we need in order to make that happen. That's, I guess, more awareness. That's what we're gonna try to build into the budget, at least a 3% for the achieves level, and then at least a 5%. We always try to create a 2% gap to create an incentive to be a high performer in your performance evaluation. So we'll bring that back to you to the April meeting with a balanced budget for your approval. So thank you.
I don't know about your county, Kuwait, are you guys looking at a 3% increase?
We haven't really talked about it yet.
Yeah, we're just getting into budgets in the counties right now. Won't do until the end of September, but I'm guessing we're probably looking at 3% bump there too. What's really important for everybody to understand is that if you have 700 million in new construction throughout the year, take that times your levy rate, that's how much cash you create from that growth. That usually covers that 3%. There are some counties that are actually losing values. That's on the other side of the scale. Okay, we're gonna move on. We got here, next to that. We're at our 10:30 agenda item. This is an action item. Discuss and vote on purchasing the medical van unit. And Laurel, are you doing that?
So just for, I guess, some history on the van idea, a lot of our staff are interested in using that across the agency, epidemiology staff, medical staff, community outreach, doing health screening clinics, dental clinics. So in August, we had proposed in our carryover funding $100,000 for purchase a medical van to allow those services to be delivered out in our communities. At that point in time, the board advised it's not going to be enough. Why don't you guys go back to the drawing board, do some research, which we did, spent more time with our teams across the 2 divisions, community and environmental health and family and clinic services. And at the last meeting, Stephanie presented some different mobile van options, new options. It came to around $229,000, and that would be brand new, fully equipped, have everything we need from refrigerators, freezers, hand sinks, gray water, ADA lifts, awnings, actually wrapped with the CDH logo. And we have the additional money now to make that purchase. And that essentially comes from salary savings, which we have every year. That's the biggest portion of what we carry over into the August board meeting and ask for the board to designate that cash 27th pay period, IT infrastructure, and so on. So we already have 100,000 designated. This would be about $129,000 that we would need in order to purchase the van that our staff feel like would best meet our needs. And this isn't a, for the next year or two, we're planning to use this for the long term. I know estimates were that the van would be used at least 3 days a week, pretty much year round with the various services I described. Ultimately, we would like to be able to provide similar services as we provide out of the office to include primary care, although that's not part of the initial plan. Also down the road, depending on how successful it is and how much of utilization it gets. That's something we would certainly be monitoring, how many patients we serve, how many health screenings we conduct, and that information will come back to all of you. So this is what was proposed based on the guidance from the board up to and through the last meeting. I know there's other interests in it. Dr. Birch, you brought up at the last meeting, possibly looking at used vehicles and retrofitting those, which I know Laurel has some information on that. To retrofit vans that aren't specifically designed for this purpose, it's quite expensive. It's almost like the cost of building a home compared to a remodel. Remodels tend to be really expensive, and I think that's essentially what we found. I'm aware that it sounds like Ada County, maybe Commissioner Davidson found a vehicle at St. Luke's. He has not talked to me specifically, so I'm not sure what that looks like. So what's before you is an action item. It'd be to authorize CDH to go ahead and proceed with purchasing a medical unit van that you saw at the last board meeting. I can, I have handouts on that. So that's the ask, is to authorize us to make that purchase. And I know it'd be 8 to 10 weeks out before we'd be able to pick up the vehicle and ready to roll, probably closer to summertime, which is when we do a lot of our community work and outreach.
So 2 questions. One, did we pay sales tax? Do we have to pay sales tax?
No.
We're exempt from that.
Correct.
Okay. And the total is what, 229?
229,000.
And that gets you everything that you need in it and on it, stuck to it?
Yes.
Okay. What's your pleasure?
Frankly, I make a motion to hold the decision for 1 month, because I can speak to the van, the vehicle that has come to light this week at St. Luke's. And if I had Dustin's help, I've got pictures that I took on a thumb drive that I can show of that vehicle. And I can go into a little bit more of what's come about. If
Dustin, can you come in and help us with the?
They'll need to check your thing for virus.
They couldn't see.
I took some pictures off my phone. So if I'm speaking to my motion, what has come to light is Ada County has a fleet manager. Commissioner Davidson brought up this issue with the fleet manager. That fleet manager was the fleet manager for St. Luke's. And he was aware of this Class A motorhome that St. Luke's has had for 3 or 4 years, that has already been converted, and they used during COVID years for 2 years to do remote vaccine clinics. It has sharps containers. The back end is a toy hauler. And so what they did is they can lower the back end down, and they had that open area for a sitting area. So at post-vaccination, you have to have that cooling period and so forth. And so this Class A motorhome has the awnings, has the back end, has a ramp, and it elevates. So it will come down at an angle, using for personal use. You would drive your 4-wheeler up into it, but it also acts like an elevator that could be used for handicap accessibility. When it's out and down, it can be set up as a patio, so it can be used as events. It's got slide outs. It's got an entire bathroom, not just a hand washing sink still in it. They've removed, that's it right there. They've removed some of the beds and stuff, and they had benches put in. And so that thing has been parked there by the annex at St. Luke's for the last 2 years. And the fleet manager said that the security has been going out and starting it, making sure it's serviceable. It was bought, the St. Luke's fleet manager at the time said it was, there's a good picture of me trying to take a picture of the inside. But you can see the sharps container mounted in the back. It's got a grab bar. That's the refrigeration. They didn't have the expensive fridge in it, but they had the monitoring system on the fridge. St. Luke's put over $50,000 apparently into solar panels and a battery system that is charged by the solar panels, so that thing can be off grid for lengthy periods of time. And it's basically all been set up to do exactly what we've talked about. The back end can be used for screenings. The dental chairs can be set in the back end where the toy hauler part is.
And it has about twice the square footage of a.
Yeah.
Sprinter.
What's the mileage?
You know how much they want for it? Is
It's less than 1,000. Well,
Less than 1,000 miles.
less than 1,000 miles. So I had a conversation with the current St. Luke's fleet manager. They were already in the process of disposing this. They were talking just recently with dealerships, and I don't know if it was to consign that vehicle or to sell it to a dealership, but they are in the process of getting rid of it. So they've already internally decided that it is not something that St. Luke's wants to keep on hand. And so the fleet manager that is now at Ada County but was with St. Luke's knows that that didn't come out of his fleet budget. So it was purchased with what appears to be taxpayer money, you know, the COVID federal printing press money. So in a nutshell, the taxpayers have already paid for that vehicle, it appears. And, you know, what we would hope is that, you know, I can't speak for St. Luke's or the legal team or anything like that, but, you know, from the taxpayers to the taxpayers, and acquire something like that at minimal to no cost that's already retrofitted to be a mobile vaccination and then some vehicle. And so their fleet manager, the current fleet manager, has already floated the balloon up the legal team and stuff at St. Luke's. I just hadn't heard anything back before today's meeting, which is why I would ask that maybe we put a pause on this decision for a month to maybe acquire information. And there is no 6-8 weeks or months delay to build or anything. If they're that hot to get rid of it, once the legalities and hoops are jumped through.
Does a rig like that you have to have a CDL?
No,
Class A.
it's a class A,
Class A,
so,
okay.
so anybody can drive that. Now you gotta be able to judge just how high the tree branch is. But, a standard driver's license is eligible to drive that vehicle. So you could just imagine that thing taking up 24 parking spaces out here or something. But from it's got a Ford chassis, and with less than 1,000 miles, it is a brand new vehicle.
Yeah.
Yep.
Brand new. It's got
That's
all the electronics, backup cameras, all the generator, sensor, solar stuff. I mean, it's a rig. I looked at the video on that Ford model, but.
Eddie, get it.
Yes, Mr. Chair. Dr. Furch, the toy haulers I'm familiar with, the ramp all slope. So would that be an issue with our ADA? How would we?
The angle?
Yeah.
I wondered about that because when I did my building, ADA requires certain grades of ramps and rails and stuff. Apparently this one will also act as an elevator. So it goes flat and creates that patio effect out the back.
Well, St. Luke's is a nonprofit, it's already been paid for by the taxpayer.
Well, and that's what
Yeah.
I was thinking, some good PR and leverage a little. You lived off COVID money for how many years, and let's give some of the.
Gesture.
I think this is awesome, and I appreciate your effort looking.
I do
into it.
too.
I think what we maybe ought to do is delay this decision and get your guys and your department heads that are gonna use this to go out and take a look and see. I'm sure there's gonna be some things we're gonna add to it that maybe.
A wrap or something. I get a wrap.
Yeah,
Yeah.
Right,
Take the St. Luke's off.
right,
Yeah.
just
Yeah.
cross it out.
right.
We could get some tagger on back and tag the back of it or something.
Well, and there's companies that do all that detailing
sure.
down
Oh,
here,
sure. But it would
especially
be a
Garden
lot
City,
easier.
and then find out what it's gonna cost.
Yeah.
Maybe they'd be willing to donate. I don't know.
Well, I'm gonna like see the powers that be that can try and leverage whatever we can leverage out of it, but it's been sitting there for 2 years doing nothing.
Well,
Mechanically, if they.
Well, the fleet manager, the current St. Luke's fleet manager says it's fine. The current security people there have the keys and they go out once a week and start it.
it's a diesel or gas?
Ah, boy, I'm not even certain on that part of it. It's a Ford chassis. And so when I looked at the video regarding the warranty for that particular thing, it had like a 12-year warranty on the motorhome part itself
Sure,
and things
sure.
like that. And for those that know about vehicles and Ford engines, that it's not even broken in yet. That's right.
Well, I think we need to look at all of our options, look at everything that's available and what kind of, this is really what they call a puller, because the engine is front instead of the back, which is called a pusher. And they're really different concepts, but I really appreciate the fact you're looking around and that's good boardsmanship as far as I'm concerned. Let's go check it out.
Thank you.
Yeah.
I'll say initially, we were wanting to go smaller to start with, to get used to driving, also just the transportability, to be able to go to multiple locations in a day. Oftentimes our clinics or what we're doing are shorter duration. I think when we looked at these, some of our partner locations, the balancing, the having to dump whatever for the full bathroom and water system. We wanted to go with the gray water tank, not have to worry about the balancing, and just have a little bit more ease of transportation. But if a potential donation or limited cost option is on the table, I think we could learn to work with some of those things that we weren't looking at to start with.
What I'd like to do then, instead of your motion, deny your motion or approve, let's just table this until when May meeting? April meeting,
April.
and see what you guys come back with. And then we'll know costs, and what else we're gonna have to do to get it up in scope and.
Thank you.
Thank you again.
Yeah, thank you.
Okay. So then we're gonna write postponed on that. And then we're gonna go down to the director's report. This is not an action item. This is just a director's report.
Yep. So there's one bill I wanted to bring to your attention that impacts really access to healthcare for anyone under the age of 18. So it's Senate Bill 1329, Parental Rights Act. And that bill is now law signed by the governor. So essentially what that does, at least with our read, and when I say our read, all the public health district directors, and we're going to need some guidance from legal counsel on what this will mean for us going forward. It'll go into effect on July 1st. So what the bill describes is that no one under the age of 18 can receive healthcare, any type of healthcare, anywhere in the state except for emergency care without first having parental consent, parental permission. So at least at first read, if a 17-year-old wanted to come into Central District Health or Primary Health or St. Luke's or St. Al's or any other organization to receive a vaccine, that provider would be prohibited by this law from administering that vaccine without first having parental consent. Obviously, here at Central District Health, for all the years we've been in operation, we always encourage parent involvement or guardian involvement or some responsible adults involvement with any type of healthcare. But our clinicians, nurse practitioners, registered nurses have made that determination that if there was reasons why the parent could be involved, maybe it's seeking birth control, for example. And if, again, thinking about a 16 or 17-year-old
going into a medical clinic to seek birth control, but they didn't feel comfortable having their parents involved with that, then we would provide those services to that individual. Everything's well documented, of course. So one thing I don't know is there are other laws out there that allow for testing and treatment of communicable diseases, sexually transmitted infections, or younger ages. So I don't know if this law supersedes that. So I'm not giving you a legal analysis. I'm giving you my first read on it and the impact that it will have on access to care throughout the state of Idaho. The second part of that bill is then parents will have access to those child's medical records. So they would just request that child's medical record and we would have to provide it. I assume HIPAA laws would protect that information, but I don't, because that's a federal law, which would supersede the state law, but I don't know that for sure. So this is awareness for you. It's not something that can be undone. It's going into effect on July 1. So I'll share more information probably at the April meeting. Working closely with the other district directors right now, and we'll get some more legal guidance on that. So just more of an update. It'll certainly change the access to healthcare for people under the age of 18 in Idaho. The second, that's all I have really for legislation. That's a bill. There was a lot of bills kind of came forward this year about lots of topics around public health. I think this will be the one that will have the most profound impact on access to preventive health care for people under the age of 18. The budget. So for the budget hearing, we always have the budget hearing that is immediately followed by the Board of Health meeting for May. So it'll be a normal board meeting. The budget committee meets first. Often it takes about 10 to 15 minutes or sometimes less. So we're going to start that at 10 a.m. on May 10th in Valley County. And there could be more options, but the two options that we came up with is one is to have the meeting at our office in McCall. And I'm sure probably a lot of you have not been there unless you've been on the board for a while. The conference room's pretty small. It holds probably more comfortably about 10 people, and even that's a bit tight. The other option that we came up with that Donna researched was the Hotel Novo.
It
And
used to be the Ashley in Cascade.
just on the right as you go, just as you're heading out of Cascade on the right, heading north and we did have our budget committee meeting there and the board meeting however many years ago that was. And it holds around 25 people, so it'd be plenty large enough. And then it's $200 for a 4-hour meeting, which I'm sure we would be done with the budget committee meeting and the board meeting in that 4-hour window. And so that's the options. We can either do it at Novo, our office in McCall, or if you have some other research you'd like us to do, we can do that. So just want some guidance so we can get that planned and motion.
It's really up to you guys how, if you want to drive to McCall, you want to drive to Cascade to make the meeting. It's really.
I remember being like stuffed sausages in the room, in our office.
That's pretty nice. And just so you know, Novo stands for northbound. They just shortened it to Novo. It used to be the Ashley.
Oh, that was
But
anything
it's a
but
200
Boise.
No Boiseans, yeah. And I think it's a $200 charge for that room, but that's okay too.
Yeah, it's pretty small.
We could put out lawn chairs at the Water's Edge campground and just
It's nice weather.
sit around sit along the river.
Yeah, if it's warm in May, who knows?
IT might be a little difficult for that, but yeah.
Yeah.
The IT is gonna be a problem anywhere in Valley County because we just don't have internet, but it's coming.
We did just put a new Teams room in our conference room in McCall, so there's a little more space than there used to be, just got rid of the furniture and the big, it's now much more sleek Teams room. Not that it wouldn't still be very tight quarters, but we think the technology there would be slightly easier.
Probably better than the Novo. So what's your pleasure? If you've never seen the McCall office, might be a good time to go up and see it. Your picture's hanging on the wall.
That's from
setting up and tearing down and stuff, is that easier to do on your location than it is to go to an outside location? As far as IT goes.
Here, if we went to our office, it's already set up because it's set up like this room. If we go there, they don't have the ability to do it. They have Ethernet and we have to bring all the equipment with us. So we'd have to set it up and do it since we at the hotel. And then we have to bring in our own
It's
computer
about the same
there also.
friends, too.
So they don't provide food either.
So it's a small room with the tech or comfortable room without the tech?
It's spotty energy.
Well, do we have to YouTube this meeting?
Do we have to?
It's probably the most important.
I mean, we've only done that, really, we started doing that during COVID because of the significant public interest. I know the interest has dropped off pretty dramatically, so it'd just be, we're not required to do it.
I'm not saying stop it completely, but for in this case, if we don't have the broadband, which I'm pretty sure is gonna be tight, Cascade.
Yeah.
If we don't
Would we
YouTube.
stand out to the public if we didn't?
Oh,
pass
yeah.
the budget.
We talked about this on it because we YouTube our county commissioner meeting. And immediately we got comments during the meeting, during the discussion, no, you can't stop. Don't
We
stop.
can do that.
We can. Dustin said he would do it just like he does here. He's in his back room. We're just there.
Let's go to the office.
Love it.
Go to the office.
Okay, so this is not next time. So we will meet then at the McCall office, May 10th at 10 o'clock in the morning.
I'll just say that if someone would not want to drive again, they would have the opportunity to join in by teams. So, and for the board, for the budget, it has to be a commissioner. So if Ada County commissioner would not want to come, they could do a teams.
Or they can do a proxy.
But they can only proxy to another county commissioner, which that still leaves someone. That's what the law says.
Okay.
Yeah.
Changed.
Yeah.
Oh, it
Yes.
Changed.
It changed, yeah.
Yeah.
I guess I better show up too.
Well, you're the chair because it's
Oh.
your county. You're the double chair.
The chair.
Well, it'd be great if Rod or any of those guys want to come up or something.
Yeah, I'm not saying it couldn't, I just give them options.
Okay, everybody good on that? Oh, you have one other. It's not on here. We can't talk about it.
No, these are general ideas.
The general ideas. This is what gets
Specifically. So this is just more, again, for information. I'm not sure it's really, I wouldn't say it's gaining any traction, but some board members at other health districts have introduced the idea of wanting public health districts to change their fiscal year from the state fiscal year, July 1, to the county fiscal year, October 1. So we're working on pros and cons document. This is likely going to make its way to the Idaho Association of Local Boards of Health meeting in October. So I don't know if it'll be the April meeting or the May meeting, but I'll share that with you as far as, obviously it doesn't need to be done. It's not going to get done for this year. As we're preparing our budget to start on July 1, but that will be a conversation that likely will occur at the October annual Local Boards of Health meeting in Idaho Falls this year. So that I'm just giving you a heads up. This is coming. Laurel and I've talked about it. Conan, as far as the logistics of making this transition, there's not a lot of pros to there's not a lot of, I guess, reason to do it. It's worked this way for only about 54 years, so I'm not sure why we.
And I don't know why it wouldn't matter to the counties either.
No, your money comes in at different, it's not like you pay us on October 1 or pay us on July 1. So, yeah. So just a heads up, these are ideas that come forward and you'll be part of the debate in October if it even makes the agenda.
Okay.
Why can't districts, counties, states use January 1 like the rest of the civilized world?
Yeah, I don't know.
When you figure that out, let us know. will you?
Right.
That's all I have, Mr. Chair.
Okay. So is there anyone in here, for public comment? Anyone online? Anybody, I guess there's nobody out there. Hey, does anybody else have anything you want to talk about before we adjourn? Long meeting. Oh,
For your adjourn, I did look at the numbers for social security. We're looking at about $800,000.
oh, big chunk of change.
Thanks, Scott.
Thank you. Yeah, appreciate that.
And we'll, obviously, we got a little bit of time between now and the vote, so this will be, I guess I could call it a standing agenda item. I think it's important for this board to talk about this and then figure out the timing of coming to a decision on what you would like to do with the district's contribution to social security. And we'll research a little bit more, obviously, the Percy Choice Plan, the 401k plan. Sounds like that's what others have done, according to what Jackie had shared. We also have a 457 deferred compensation plan. I don't know why it wouldn't be able to go through that mechanism as well. Maybe both at the employee's preference, since we have the choice to do that. Choice as in Percy Choice or deferred compensation. So anyway,
Well, I think it's really up to the employees,
Up to the employees.
right.
whatever they feel like they want to do, we'll do it.
Yeah, I think the point of this is just to, Jackie encouraged the board to make the decision ahead of the vote so that they can make an informed decision when they vote. What the board has authorized to happen with that money. So maybe by May is when I'm thinking we need to make that decision, because unless we have a special meeting, you won't meet again until August, and then it sounds like that's about the time the vote. The election, the selection will actually take place.
I had sent Jackie the invite for the April meeting to have it be an action item at that point, but you could come again then for questions and then come to the May for the action item, assuming she's available. I
Sure.
haven't checked her availability for the May
We're
meeting.
going virtually for May if she needs to.
Well, I guess there being no other business, I want to thank Dr. Cole for being here. Appreciate you being in person. It's nice to see you again. You get him way too much sun, I can tell you that.
So it happens with spring farming.
So with no other business, this meeting is adjourned.
Thank you.